right, I think we should get going. I see that we definitely have a quorum. I believe everybody on the PNC committee that was participating has joined the call. Want to just check that you can hear me okay? I've been told that I'm quieter than I normally am.
That last was just a little bit better. The first I could hear you very well.
Okay.
Yeah, you sound like you're far away.
Okay. Interesting. My microphone is fighting me.
Good.
Exactly, for you and your ears. All right, I've turned off the doorbell, so again, the co-host, if you can help me admit people. But again, we have a pretty robust agenda we're going to try to make it through today. New first time we're doing this remotely, so we're working through our Zoom functionality. I have made all of the committee and staff co-hosts, so you should be able to unmute yourself. Please, use that functionality to participate in the conversation. If we start to have topics where a lot of people want to have input, we can use the raising your hand function. We have people that have signed up for public comment, so I appreciate everybody signing in with their names. I can call you if you signed up in advance and provided a conflict of interest declaration. So with that, if we can switch over to roll call and introductions.
Yeah, if we could follow the order of the slide, I think that would be easiest to facilitate.
Sure. This is Tracy Klein. I'm a family nurse practitioner and the public member.
Bill, I think you're next. I haven't seen Karen join yet, unless she's somewhere in the list here.
I'm Bill Warrior. I'm a family physician. I am residency faculty at Svr Family Medicine Residency.
Hi, everyone. I'm Jim Slater. I am a pharmacist at Care Oregon. I am the chair of this committee, and Care Oregon serves 3 coordinated care organizations, Health Share of Oregon, Columbia Pacific, and Jackson Care Connect.
Good afternoon. I'm Mark Helm. I'm a pediatrician here in Salem at Childhood Health Associates. I'm also the board chair for the 11 Health Council, which is the health council affiliated with the Marion and Polk Pacific Source Community Solutions, CCO.
I'm Russ Huffman. I'm a psychiatric nurse practitioner here in Salem at Salem Health.
Jim is not with us today, so Kathy?
Okay, Kathy Zaring. I'm the pharmacy manager at Salud Medical Center. We're part of Yakima Valley Farm Workers Clinic, and I work in Woodburn.
Hey, everybody. Pat DiMartino. I'm a pediatrician and hematology oncology fellow at OHSU.
Hi, everybody. Dave Pass, medical director for Regents Health Plans.
Hi, all. I'm Stacey Ramirez. I'm faculty at OSU College of Pharmacy and the director of pharmacy and clinical pharmacist for the community health centers of Benton and Lynn counties.
And Karen, I see you joined us, and I made you a co-host so you could unmute yourself, so please we'll refer to you.
Hello, this is Karen Michelson. I'm the director of pharmacy for the Coquille Tribal Pharmacy in Coos Bay, Oregon.
Great. And as we're used to working our way around the table, we've also made a list for staff. And if we just want to work our way from the top. Jennifer, you might be muted, but we're starting with you. All right, well, we'll skip on. Jennifer's executive assistant to Trevor Douglas. She's helping us run the meeting today. My name is Roger Citron. I am the program manager for the Drug Use Research and Management Program. We help provide clinical support to the OHA. Trevor isn't with us today, so Dave, we'll pass on to you.
All right, I'm Dave Engen, clinical pharmacist at the Drug Use Research.
Hi, this is Sarah Fletcher. I'm one of the pharmacy clinical coordinators with OSU.
This is Andrew Gibler. I'm the pharmacy director at Legacy Mount Hood Medical Center and also part-time faculty with the OSU Durham Group. with the Durham group.
Megan hasn't joined us yet. Megan Herring is with us part-time, subject matter expert for several of our topics. She'll be joining us a little bit later in the meeting, but she was a previous clinical coordinator, also works as a professor up at OHSU.
And I'm Rich Holsapple. I'm the pharmacy manager for DXD Technology. We're the pharmacy benefit administrator for the state.
Hello, this is Deanna Moretz. I am a pharmacist with the Durham Group.
Hi, this is Kathy Santana. I'm a pharmacist with the Durham Group as well.
Hi, my name is Sarah David. I am PNT clinical co-coordinator for the Durham Group.
And I'm Deborah, or Dee Weston, Pharmacy Program Policy Advisor for the Oregon Health Authority.
I'm Brandon Wells, Pharmacy Program Analyst at Oregon Health Authority.
And Jennifer, I think I had to make you a co-host again. If you wanted to introduce yourself, I tried to do you justice, but everybody can hear your voice.
Hi, this is Jennifer Bowen, Executive Assistant for the Oregon Health Authority.
Great. And a little bit later in the meeting, when we get to the hepatitis DAA topic, we'll have a resident with us, Anthony McKenzie. He can introduce himself at that time. Conflict of interest declaration. Conflicts of interest declarations are filled out by all the P&T committee members, as well as all the staff and contractors. So those are kept on file with the OHA. We kind of went over at that length in February, but at this time we also see if there's any conflicts any committee members need to disclose that haven't been reflected on your disclosure or to the committee. Okay. Hearing none, the next phase is the approval of the agenda and minutes. For those members that are on the phone and maybe following along with the packet we have posted online, that's page 5 in the packet. I sent out the minutes to the committee members in advance so that they could review those. Just give you a second to look them over. Let us know if you have any edits. If not, we need a motion to approve.
This is Russ Huffman. Motion to approve. Second. Dave Pass.
All in favor? Aye. Say aye.
Aye.
Anybody opposed? Motion. Minutes are passed.
And before we go to Dee Weston for the department update, Dave Pass, thank you for just identifying yourself before you seconded. I think that's a useful tool if we can get in the habit of that. If we speak into a conversation, identifying who you are will help the committee members orient with who is providing that comment. So thank you for that. And so Dee, I'll turn it over to you.
Hi, yeah, thank you. Dee here. I'm going to fill in for Trevor. If it sounds like I'm reading from a script, I am, due to their comments that Trevor kind of prepared, wanted me to relay. So, with that, just a few topics he wanted me to provide. One is donated hydroxychloroquine from Amneal Pharmaceuticals. Amneal is a generic manufacturer, you probably know. They donated about 50,000 doses of hydroxychloroquine to Oregon, and that supply doesn't expire until 2022. Having received this, we worked together, OHA's Office of Delivery System Innovation, pharmacy team, worked together to develop a vetted strategy to monitor shortage and access within Oregon for all indicated uses of hydroxychloroquine. After some research at this time, we don't know of any shortages that are impacting access. We want to ensure that this donated resource is used in a clinically prudent manner for indicated conditions supported by the best evidence possible. And the strategy that we worked on has been vetted also through the senior OHA clinical leaders. That's item 1. Item 2 is similar. It's donated supplies of remdesivir, which is, of course, an experimental, non-FDA-approved drug for the treatment of COVID-19. It has emergency use authorization only at this point. We received in mid-May and expect to receive more. We received in mid-May about 80, a supply for about 80 patients to receive a 10-day treatment. OHA clinical leadership worked with OHA's Office of Delivery System Innovation and the Office of Equity and Inclusion and the OSU DERM team to develop a criteria for the most appropriate use of this medication. And that research document is posted publicly. I'm sure we can share it and add it to the minutes, add a link to the minutes if you haven't seen that already. Third item is in an effort to stay connected and share best practices related to COVID-19, OHA facilitated additional meetings with CCO pharmacy directors over the past 6 weeks. And we appreciate the CCO collaboration in these meetings and recognize Jim Slater and Robin Trevor in their roles as co-chairs. Item 4 concerns budget projections. Most of you by now have heard of the economic forecast, and the budget projections don't look particularly good for Oregon, unfortunately. However, it isn't yet clear what this will mean for OHA. There are posted proposed reductions, but we don't yet know that what the governor's direction will be or whether it will impact the PMT's charge to manage the PDP or the preferred drug list. As news surfaces and information becomes available, Trevor will provide additional updates. And then finally, Trevor wanted to express OHA's appreciation and recognition of the PMT's contributions. We realize that most of you are also frontline providers serving Oregonians in this unprecedented time. And we very much thank you for doing your part for those efforts and also serving on the PMT. So on behalf of OHA leadership, we value very much your contributions, whether it be in direct patient care or administrative. We want to know that you are valued. Thank you very much. That's all I have.
Thank you, Dee. Is my voice a little bit better now? I tried to play with my setting.
No, it's a little quieter than usual. It's unusual for us to hear Sarah better than you.
All right, well, I will keep playing with it. So at this point, we're just going to try to provide a quick little COVID-19 update. This was the request of Chair Slater. So kind of building upon some of the information that Dee said, when we first, and this is for the fee-for-service program, so it informs really some of our DUR policies and PA criteria. So mid-March, we sent out a fax blast to pharmacies notifying them that they could do early refills for members, that they could also fill maintenance supplies, so 3-month supplies, and reminding them that we have a mail order contractor. We shared that information with the CCOs. At the end of March, we turned off our edit on non-preferred PDL drugs, so those would no longer stop for PA. Those would fly right through. One topic we'd want to talk with the committee about is we're thinking about turning that edit back on, so non-preferred drugs would stop for PA. But now that we have some new starts, who should we grandfather and, for how long? We also stopped some of our DUR initiatives just because we know offices weren't staffed and we didn't want those going into the void. So we kept our safety edit on, but we stopped some of the change forms. We stopped enforcing provider enrollment. We went out and pulled prior authorizations that were about to end, and we extended those, again, because we didn't think providers might be in the office, and we do not interrupt therapy. So we identified prior authorizations, those that had been loaded for a previous 12 months, we gave an additional 6 months. Yes, the previous PA was loaded 3 to 11 months. We have added on an additional 3 months. Shorter PAs for 1 to 2 months we did not extend. Those were new starts and often for, intermittent or short-term therapy. We did that a second round again about a month ago, so at this point we don't anticipate extending PAs any further, but that was just a process that we took to make sure our members had coverage. Mid-April, we sent out a notification to our pharmacies that the other coverage code 1 was reauthorized. That allowed pharmacies to bypass insurance when a member no longer had that. Just some questions about staffing and making the system not recognize people no longer having insurance. Trevor's comment about the donated hydroxychloroquine, we were concerned about shortages. We pulled data from the fourth quarter of 2019 to see who had been using it chronically for FDA-approved indications. We then looked at claims for continued enrolled members in 2020, tried to see if they had recent claims or 90-day supplies. Those are the members that I reached out to. I called pharmacies to confirm if we didn't see a claim and got confirmation that there were not any shortages. They had sufficient numbers in stock, and we're still getting it from their wholesalers. So it was one of the steps we took. So overall, we worked with DXC to the front line for us. We have noticed in our report that in March, our claim volume went up, physical and mental health drugs, not surprisingly with those early refills being used. And in April, the claims dropped back down a bit. But we did say an increased cost for some of the claims, particularly the physical health drugs, which is indicative of non-preferred drugs going through without restriction. So another signal that our edits, turning those off, were changing some of our market share reports. And overall, there was a decreased call volume to DXC. Any questions, kind of what steps we've taken at the OHA? All right. With that, I just wanted to add one additional here, a word from the chair. So, Jim, you wanted to make some comments before we dig into the meat of the agenda.
Yes, hello everyone. I just wanted to particularly extend a welcome to you to this committee meeting. As you know, the last time we met was in February, so a lot has changed and happened in the last 4 months. And in addition to this responsibility, I am the Emergency Operations Center Pharmacy contact for the Metro, for the Tri-County, and that has allowed me to really see healthcare professionals in all walks of life really contribute in amazing ways to Oregonians to help us through this. Super proud of everybody in watching that. And that includes the pharmaceutical industry providing what they can in the way of medications. We heard earlier about hydroxychloroquine, Remdesivir being provided to the state to help us. And so all of those efforts are extremely appreciated, and I want to particularly call out our P&T members who are providers of care to Oregonians, and just my respect for you in figuring out how to continue to do patient care through this new COVID-19 experience. And that raises something as a committee that I think is worth noting. All of us are adjusting, and we need to help the Oregon Health Authority and help this committee adjust as well. What does it mean to have a pharmacy and therapeutics committee with formulary and utilization and safety and quality oversight? What does that mean, and what does that look like as we learn from COVID-19? And help us to think about if we need to make adjustments to what we've done historically or what we need to do going forward so that the people we serve can continue to have access, can continue to receive medications in a safe, effective, and good stewardship responsibility that we all are required to think about in evidence-based medicine practices. Today's committee meeting is going to be a bit of an adventure for us as we adjust the committee to this new structure, and so we appreciate you helping us through that. We're hoping that everybody participate in a more normal approach, and what that means for committee members is as we present information to you today, we would invite you at the appropriate juncture during the slides to ask questions along the way, just like you would when we were meeting in person. You don't need to wait till the end of the presentation, and in some instances, they're best addressed when that information is in front of us all. And we'll work our way through it, and Roger will help guide us and others if too many people need to speak at the same time, and don't worry about that. And so help us through this meeting, and we just want to acknowledge you on behalf of the Oregon Health Authority and the Oregonians we serve for your contribution today, and those of you who are visiting the meeting, we appreciate you so much. Thank you very much.
Great. Thank you, Jim. The next section of the agenda is the consent agenda. I sent out the quarterly utilization reports in advance to the committee, as well as the P&T annual report, which really is mandated by the legislation that enabled the P&T committee, but it matches the CMS annual report and reflects the work that the committee did from October of 17, through end of September, or 18 through 19, and that matched the CMS fiscal year. So we'll be running those reports again. We also had some class updates and some adding drugs to the orphan drug policy. So we wanted to check at this point if any committee members wish to talk about any of these subjects individually, and if not, we need a motion to approve the consent agenda recommendations.
This is Kathy. I just had a couple comments regarding the anti-epileptic. I just wondered if there was a safety alert when there's a valproic acid for a childbearing woman that comes up.
That is a great question, Kathy. This is Deanna. Rich, do you know, has that been built into the prescription processing?
Right, that edit would come from FDB.
It would be an edit specifically for what?
Valproic acid and pregnancy.
Well, childbearing age, yeah.
Well, it's not going to be based on childbearing age. The pregnancy pro-DUR alert only shows if the client has been pregnant or has a diagnosis of pregnant in their history. And then the drug would have to be identified as a severity level 1, which is basically what used to be pregnancy category X. That's the only time the alert's going to hit. So if it's not that severe or the client has not have a diagnosis history of pregnancy, the pro-DUR is not going to set.
So Kathy, are you, again, it's not part of what we are discussing with this class update. Are you suggesting we go look at the evidence for that and maybe consider
Yeah, I was just, when I was reading over the guidelines and stuff, I thought, well, maybe we should kind of think about this and address it maybe. Maybe something we need to look into. If we had any statistics.
We can go look at statistics and also the evidence and see if we propose a PA criteria for those drugs, valproic acid, and for childbearing age. And so we can discuss it as a team internally, look at the data, and bring it back.
Thank you.
You bet.
I think that would be great. I don't know if we need a second on that as a motion, but I think that would be an excellent idea.
Yeah, and that's not really what we take a motion on and take votes on, or for changes to the preferred drug list or the PA criteria, since this committee serves as the rules advisory committee for those particular rules. In this case, it's a DUR activity, so we'll take that away and bring it back, and no formal action is taken other than us listening and responding.
This is Russ. Could you also possibly have a breakdown of prescriptions by provider type? I just mentioned that because I imagine, as with previous edits, psychiatrists, psychiatric nurse practitioners, and neurologists, and people who use these routinely probably have that drilled into them pretty well. So I'm just curious if we can get that also.
Okay, so what I'm hearing you say is for the valproic acid, when we take a look, see if we can delineate the provider type and see if that informs, who's prescribing it. The difficulty there is even if we find something, provider type is hard to trust as far as edits, but we hear you, and we'll see if we can have any data to support that or paint a better picture. Thanks. You bet.
I think this is a great example of helping us continue to think about the children population and where we can find DURs to support that. And maybe this yields next steps, and maybe it doesn't, but it's a great example of putting on our children population hats and finding areas of opportunity.
You bet.
Yeah, and I would also say, too, that the concern would be people who are taking Depakote, or I should say women who are taking Depakote in childbearing years who are not covered with effective contraception.
Great, we'll take a look. And if there's nothing else in the consent agenda, we need a motion to approve the consent agenda topics.
I move to approve.
This is Kathy Daring. I second it.
All in favor, say aye.
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 Anyone opposed? Motion passed.
Great. Since the P&T committee also serves as a DUR board, we have some DUR-focused activities. Those include prospective DUR and a retrospective in our newsletters. If you're following along in the packet, we're turning to page 150, and we'll turn it over to Rich Holsapple with DXC to talk about the ProDUR.
Yep. And the slides are following. Good, thank you. All right, so this is just a general overview of the ProDUR alerts and the numbers associated to them for first quarter, which is January through March. We had a spike in the number of early refills, mostly in March, because that's when everything kind of started, and the early refill was loosened. In fact, we even sent information to pharmacies to tell them how to do early refills to help people be able to stock up on their medications before staying at home. So we did see a number of alerts go up. We definitely see the percentage of overridden also increase due to that. And you can go to the next slide.
Can you remind us on the early refill whether they can get more than one?
No. They could do an early refill and then a day later override another early refill.
Okay, I only bring that up because many of us are seeing most of the time it's being used well, but we're seeing some weird behavior.
Mm-hmm.
And so I think keeping an eye on that is worth it because there are certain patterns that don't make sense clinically.
Yeah. And we have seen that pharmacies, because we don't have a limit to how many early refills can be done, we have seen pharmacies use it in that way to do a 3-month supply. They bill 1 month, and then the next day they override early refill for the second month, and then the day after that they early refill override for the third month. So we have seen that. It's pretty rare that happens. Haven't done an analysis since the COVID stuff started, but might be good to do. This chart just shows the drugs that we most commonly see with early refill, as well as the percent per total claims and then the percent of alerts overridden. Again, not a whole lot of anything to note here. The percent of alerts per total claims is actually relatively normal for what we see in previous. Percent of alerts overridden, I don't put a lot of stock in when there's very low volume, like the opioids down at the bottom. If we go to the third one, this is the one where you'll see quite a few of the reasonings for the early refill were the CC13, which we never stopped before, and now 15% of the overrides were using that code. That was the code that we told pharmacies to do, that if they were doing an early refill based on the COVID-19 pandemic, to use this code, and they, as you can see in March, complied.
So, quick comment here, sort of connected to early refill, and that is, I think it would be extremely useful, maybe at the next P&T meeting, to say something about RX PMPM month by month, to compare year-to-date this year versus last year, just to see how it's behaving, particularly with behavioral health drugs, how it's behaving during the COVID phase. You could argue it should go up because of some of these strategies. You could argue it might go down if the population is having stress and not being adherent. But I think it's worth just having a macro view.
And we can pull some of that data. Part of the challenge is those are automated reports that we pull that were in the utilization reports are pulled 6 months later because of all the encounter data. But we can see what we can do, particularly for the physical health, where we have real-time POS, and see if we can bring some of that data forward. So,
yeah, that's what I meant. Use the real-time data where you can to just have a look and let us see how it's going would be excellent.
Sounds good. And the next component of DUR is RetroDUR, page 153 if you're following on the packet. It's up on the screen, and we'll turn it over to Dave Ingen.
All right. Thank you, Roger. I'll give a brief overview of some of the initiatives and opportunities that either we, the OSU team, or you, change forms and dose-op initiatives. We've messaged prescribers about switching to an equally efficacious but more cost-effective formulation, either to reduce pill burden or maximize the potential for cost savings. These go out as faxes with pre-printed customized change forms just for the prescriber convenience, and you can see the numbers there. On 155, we also look at safety as one of our initiatives, and one of those is to help promote appropriate use of antipsychotics in children. So we identify new start patients that are less than 10 years old who are initiated on long-term antipsychotic therapy, and we link their prescribers with free consultative services through OPK, and then we track their future changes in therapy. On page 156, see the numbers we have for the non-adherence notifications that are sent to prescribers regarding patients not filling their antipsychotics, so to help avoid interruptions in therapy. On page 157, it lists the different profile reviews that we have. Many of these have been suspended during the pandemic, so not a lot of new numbers to record at this time. But on page 158, there's some other, we have some, we've notified prescribers of potentially dangerous combos of opioids and sedatives, or maybe when patients appear to be missing their respiratory controller meds after claims denial. That's the ICS LAVA. We also have a more recent one where pediatric patients were denied a TCA claim due to an age restriction, but there was no follow-up PA that was requested. We get a letter out to them. So, so there's a bunch of different initiatives going on. We've recently rolled out a prescriber notification initiative regarding high-risk patients on opioid therapy, but we also kind of ended up dialing that one back temporarily, but we plan to ramp it up again in the next few months. We'll dust off other initiatives as well, so stay tuned in the fall for our next DUR meeting. We'll introduce some new opportunities and get a chance to report on progress, and we hope to get your input for suggestions and feedback. So, are there any questions on me?
This is Russ. On page 156, this is more of a clerical thing. The initiative is titled Antipsychotics for Schizophreniacs. Two things. One, obviously it should be schizophrenics, but also I'm wondering if we could just change that to people with schizophrenia.
Oh, definitely. Yeah, that's just it's something that we have. It's really more for our analysts, but we can definitely change that. We can change to whatever we want to. So yeah, that's a good suggestion. It's a little typo in there.
I had a question on the numbers for the kids with antipsychotics. It seems like in the first quarter that was listed, there were about 990, and then that number dropped to 675. Was that just a result of the suspension of the DUR activities, or is that a drop in the number of new patients started between quarter one and quarter two?
That's hard to say, but it would be impacted by us dialing back the initiatives as well. So I would anticipate it could be a combination of both, but I think it'll be more clear as we start this up again and then look at trends when we have full quarter data to compare with one another. So
your great questions. We should have more robust data, and we'll be doing DUR-focused initiatives in August. So once we turn these back on, we can follow up and dig a little deeper. So thank you. Another component is education for DUR. One of the ways that we achieve that is through our newsletters. Those are starting on page 159 in our packet, and I'll turn it over to Kathy Centena for recent newsletters.
Sure. So in the past, we've hired a couple newsletters that we have published. The first one in December of 2019 was on CGRP antagonists and migraine prophylaxis. And then that was followed in January by a newsletter on evidence for drugs that are heavily marketed, which included highlights for Xeljanz, Ocrevus, Latuda, and Ozempic. And then just recently, last month, we posted a newsletter regarding optimizing NPH insulin use in patients with type 2 diabetes, which was recommended by Dr. Origer. Many of you provided feedback on that newsletter, and we really appreciate it. For July, in the pipeline, we have a newsletter on community-acquired pneumonia guidelines, an update on those. And then at this time, I'd like to solicit the committee for any additional newsletter topics.
All right.
Think of any. Yeah, she's in My Way Rogers, and you can also sign up on our website to receive the newsletters electronically.
Sorry, this is Russ again. I'm wondering if a topic would be appropriate. I was looking at the heavily marketed drug newsletter, and I'm wondering about possibly doing one on the effects of marketing on prescribing behavior.
Sure. Yeah, I think that would be very interesting. And not on the top of my head, I'm not certain how much has been published on that, but I'm sure there definitely is information out there, so we can look into it.
A topic to consider, and I think it might be something for later in the fall or winter, would be a newsletter on vaccination and immunization, and by then we should have some very interesting things to say, whether it's COVID-19 related immunization or whether it's the new normal and how to get immunization done as it relates to pharmacies and providers. So we might just want to see if enough information emerges there to gather and push out.
Great idea. Okay, thank you.
Great. Well, we always keep welcoming those ideas, so keep them coming. And with that, we'll keep pushing on. So we'll start in DUR old business. We have some PA criteria changes. Those are on page 164 in the packet. And we'll turn it over to Sarah Servit.
Yeah, so we're going to start out with multiple sclerosis PA update. And just a little bit of background on this update. These are proposing changes to accommodate expanded FDA-approved indications for multiple sclerosis products. It isn't an full evidence review. We're planning one of those later this year, and so this update just modifies the PA criteria to allow pathway to coverage for those new indications. We're also recommending removal of diclizumab from the prior authorization criteria since it is no longer on the market. And this update also provides a pathway to coverage for new fumarate formulations. So the proposed PA criteria changes are fairly straightforward. First is to add new fumarate formulations to the requires PA section of the criteria. And since this criteria has been posted, there is a new fumarate formulation, so I'd recommend modifying this to specify all fumarate formulations that are on the market. And then also modifying questions in each of the PA criteria that had previously asked if the diagnosis was relapsing remitting MS, and modify that to ask if the request is for an FDA-approved form of MS, since most of the MS drugs are now approved for all forms of relapsing MS. In addition, there's extensive changes to remove diclizumab from the prior authorization criteria. And in addition, I'd recommend making a few modifications to that criteria. One is to clarify clarifying the goals of the criteria, that primary progressive MS doesn't require step therapy since ocrelizumab is the only treatment that's used for that indication. And then a clerical update in number 7 of the criteria. It should say go to number 8 rather than go to number 12. Any questions so far?
Okay, well, do we have a motion?
Oh, we have one person who wanted to provide public comment if they
thank you, Roger.
Still interested, so I apologize. Let me find their name on the, we have, let's see, Brandon Yip with Sanofi Genzyme, manufacturer of Aubagio. Did you still wish to provide public comment?
Yes, I have a brief comment. Can you hear me?
We can hear you, and the clock is yours.
Hello, my name is Brandon Yip, and I am a medical managed care director at Sanofi Genzyme. I wanted to provide just a brief update on the current study of using Aubagio in pediatric patients. Primary results of our Terry Kids Phase 3 study were just presented at the 2020 European Academy of Neurology Virtual Congress this past May. Onset of MS in pediatric patients represent 2 to 5% of all MS cases and follows a relapsing remitting disease course above 97% of these patients. And Terry Kids is a multi-centered, randomized, double-blind, placebo-controlled parallel group study between July 2014 and just concluded October 2019 across 57 centers and 22 countries. Primary endpoint was time to first confirm relapse with pre-specified sensitivity analysis, including time to MRI activity as relapse equivalent. And the secondary endpoints included MRI outcomes and safety tolerability. Sanofi will be submitting the Terry Kids pediatric data to regulatory agents in the coming months. And let me know if there's any additional requests for info regarding Terry Kids. Thank you.
Any questions for Brandon? Great. Thank you. Sarah, I'll just turn the screen back over to you if you want to bring back up the criteria. Jim, we do need a motion from the committee and a vote.
So do we have a motion to pass the MS criteria as proposed with the modifications of adding all formulations for the Tumor rate preparation, the FDA-approved indications of MS, the goals changed with, you made me work for it here, Sarah, but it was related to step therapy. You want to restate that one? Really
yeah, for primary progressive MS.
For primary progressive, thank you. And then to shift for it to go to 8 instead of what it currently says, correct?
Correct.
Okay.
Stacy, so moved.
Do we have a second?
This is Mark Helm, second.
Great. All in favor?
Aye. Aye.
Anyone opposed? Motion passes.
Great. We'll continue on with Sarah. We have the oncology FDA proposal beginning on page 173 in the packet.
This is a proposal that had been requested by the committee, and the purpose is to ensure medically appropriate use of the newer anti-neoplastic drugs. So just a little bit of background. Oncology is a rapidly growing area of drug development. There's multiple new molecular entities that are approved yearly, and many drugs receive expanded indications after their initial approval. According to current Oregon administrative rule, Medicaid doesn't cover experimental or investigational services or items, including drugs. In addition, the Health Evidence Review Commission provides guidance on patient-centered care for advanced cancers, and that's outlined in your packet. So because oncology drugs are typically studied in multiple indications and have many safety concerns and are generally of high cost, a broad PA policy that requires use to align with either FDA-approved or NCCN-supported indications along with the HOOC guideline note can ensure appropriate use for these agents. So the scope of this PA is intended to apply to pharmacy or physician-administered drugs that are given in an outpatient setting. It's not intended to apply to emergency or inpatient services, so you'll see a question in the criteria asking about emergency use, and any inpatient claims shouldn't stop for PA. We recommend inclusion of drugs approved after 2008 and a table of those drugs that will require PA would be included in the criteria so that providers know which drugs require PA and which don't. And then in the future, any anti-neoplastic new molecular entities and new formulations of drugs that already require PA will be added to the anti-neoplastic class upon FDA approval, and then at subsequent P&T meetings, we'll bring back this PA criteria to notify you of which new drugs have been added to this criteria. One thing that I did want to clarify, we did hear several concerns raised during the public comment, which I would like to address. So this policy is intended to apply to only new start patients and avoid interruptions in care for patients on current treatment. So if a provider does anticipate dose escalation, for example, they can request PAs for multiple doses at the same time with the idea that they would be used subsequently. And the PA call center is required to respond to requests within a 24-hour time frame, and they often do so in a much shorter time frame, so that should be able to accommodate any urgent requests. So the recommendation for this policy is to implement PA criteria to ensure medically appropriate use for all drugs in the anti-neoplastic class that were approved after 2008 or later. And just to walk through the proposed PA, this essentially asks what the diagnosis is and allows for approval if it's for an emergency or if it's continuation of therapy. So that's questions 2 and 3 in the criteria. Question 4 is our standard question asking about whether it's a funded diagnosis. Question 5 asks for whether it's FDA approved, and that includes all the information that's in the FDA-approved indications, such as diagnosis, stage of cancer, any relevant biomarkers, place in therapy, and if it requires combination use. If it's not FDA-approved, we ask that same thing, whether it's indicated for NCCN guidelines for the requested drug. And if not, we ask if they're enrolled in a clinical trial because we don't cover the experimental agents if they're enrolled in a clinical trial. And then question 8, if it's for a rare cancer that isn't addressed by NCCN guidelines and which has no FDA-approved treatment options, we outline some of the requirements that are in the HOPE guidelines. So the prescriber should submit documentation of medical literature supporting use for the condition, chart notes documenting the medical necessity for that patient, and then documentation of discussion with the patient about treatment goals, prognosis, and realistic expectations of treatment. Any questions about that PA criteria?
No questions for Sarah. We do have some public comments. Call Maggie Ullman. She is a known face, but we don't have a face right now, so you might recognize her voice. Margaret is with AbbVie.
Okay.
The floor is yours.
Can you hear me now?
We can hear you now.
Hello? Oh, great. Thank you so much. Again, my name is Margaret Ullman. I'm with U.S. Medical Affairs at AbbVie, and I want to thank you for the opportunity to speak to you about Venclexta today. This will only be a short summary. Please see the prescribing information at rxabbvie.com for complete safety and efficacy details. A fixed duration of Venclexta treatment is indicated for patients with chronic lymphocytic leukemia and small lymphocytic leukemia. Venclexta is also FDA approved in combination with azacitidine or decitabine or low-dose cytarabine for the treatment of newly diagnosed acute myeloid leukemia in adults 75 years or older who have comorbidities that preclude the use of intensive induction chemotherapy. Venclexta is a selective and orally bioavailable small molecule inhibitor of BCL2. Overexpression of BCL2 has been associated with resistance to chemotherapy agents. Venclexta helps restore the process of programmed cell death. It has been shown to improve patient response when used either as monotherapy or in combination with other oncology treatments. In 2 phase 3 studies in CLL, patients treated with combinations that included a fixed duration of Venclexta treatment showed a significant improvement in progression-free survival. In 2 phase 3 clinical trials in AML, patients on combinations that included Venclexta, the complete response rates ranged from 21% to 54%, and time to full or partial responses were between 1 and 2 months. Safety of these Venclexta combinations is consistent with what has been seen in previous studies. In the CLL studies, the most common adverse reactions with Venclexta were neutropenia, diarrhea, upper respiratory tract infection, fatigue, cough, and nausea. In the AML studies, the most frequent serious adverse reactions included febrile neutropenia, pneumonia, respiratory failure, and multiple organ dysfunction syndrome. Patients taking Venclexta should be assessed for tumor lysis syndrome and include evaluation of tumor burden and comorbidities, and should receive prophylaxis measures including hydration and anti-hyperuricemics and laboratory monitoring. Venclexta is the only oral chemo-free regimen that offers sustained treatment for treatment-free remission across all lines of CLL therapy, and is a preferred regimen for first-line and relapsed refractory therapy in the NCCN guidelines. NCCN also recommends the 3 Venclexta combinations with... Oops, sorry, didn't look up. Thank you so much. I appreciate the chance to talk to you today, and happy to answer any questions.
Any questions from the committee for Maggie? Margaret, sorry.
No, that's fine. Maggie's good. Thank you, everyone.
Thank you. Sarah, I'll turn it back over to you if you want to bring up the criteria. With that, are there any other additional questions for Sarah on the proposed criteria? And if not, then we need a motion to approve.
Pat Martino, motion to approve.
Kathy Daring, second.
Right. All in favor?
Aye.
Aye. Aye. Anyone opposed? Motion passes.
Great. The next section of the agenda begins on page 185, but we're going to change the order of events a little bit. When we first did initial introductions, I tried to introduce Megan Herring, and we also have Anthony McKenzie that will be joining us. If you'll both briefly introduce yourselves, and then we'll turn it over to you.
All right. Hello, everybody. My name is Anthony McKenzie. I am the current PGY2 ambulatory care resident for Oregon State University, practicing at the Richmond Clinic through OHSU.
And hello, I'm Megan Herring. I'm clinical pharmacist and faculty with the College of Pharmacy. And I think we're starting with the policy update, Anthony. Is that correct?
All right. Sounds good. So I'll go ahead and get started. I will be presenting the policy update looking at direct-acting antivirals for treatment of hepatitis C. The purpose of this is to determine how the most recent prior authorization changes in 2018 and 2019 have impacted utilization of direct-acting antivirals, as well as the characteristics of patients receiving therapy. This slide here is just a timeline that can be found in the policy update itself, just briefly outlining the changes. We're going to focus more on the January 2019 and March 2019 changes as the most recent that removed the alcohol use, substance use limitations, as well as disease severity limitations. So the research questions, we wanted to see how utilization of direct-acting antivirals has changed over time with the changes in criteria. We also wanted to see if there was any changes in percentage of those prescribed by primary care providers, as well as the patient characteristics and liver disease complications and how that's changed over time. We also wanted to look at whether or not patients with alcohol and or substance use disorder have been treated with direct-acting antivirals more frequently since these changes, as well as looking at those who are retreated with direct-acting antivirals. The methods, we defined the index event as a newly started direct-acting antiviral. We included patients that had at least 75% eligibility for 1 year prior to the index event, excluding patients with Medicare Part D coverage. When we're looking at overall utilization, it was evaluated over time, looking at both CCL and fee-for-service pharmacy claims for direct-acting antivirals. And then we looked more at a detailed evaluation between March 2018, February 2019, and then March 2019 to January of 2020. Looking at our results, this chart here shows the overall utilization of direct-acting antivirals. The green line is the claim count per member per month. It is multiplied by 1,000 just because the overall utilization is still relatively low. And as you can see, the PA criteria, the red lines on here are changes in prior authorization criteria. So most notably the lines in 2018 and 2019 both had increases in utilization afterwards, with March 2019 having the sharpest increase, and it looks like this has actually plateaued at about 0.6 claims per member per month times 1,000. And then on the next slide, we're looking at prescribing patterns in general. So in the two groups, there was an increase in the total number of patients treated with a direct-acting antiviral, with a little over 1,000 in March 2018 to February of 2019, all the way up to 2,057 in this most recent year, with a large shift towards primary care prescribing from 47% to almost 64%. And then while percentage of prescriptions from specialists did go down, the overall prescriptions actually went up, indicating that we are still able to get prescriptions to patients with more severe disease as well. And then below that, in the second table, shows the proportion of the patients that are treated with direct-acting antivirals that have hepatitis C. So the number of patients with diagnosis did not really change, so about 2.5% in both groups. But the proportion of those that were treated with direct-acting antivirals did increase from about 10% to 20% with the PA criteria changes. So now looking at the demographics of the patients, the average age did decrease down to 48 years, but also expanded the minimum and maximum ages as well. We really wanted to highlight two age groups that had the most change, one being the age group 18 to 34, which increased from 8% to 18.6%. The increase in this group could be due to a couple of different things. One is that this is the group that is at highest risk for contracting new chronic hepatitis C, and this is linked to the opioid epidemic. This seems to be the age group that is most affected, as well as removing the disease severity. So this younger age group is less likely to have the disease for a longer period of time, and also less likely to have more severe disease. On the other end, we have those that were 55 and older. We actually saw a decrease in percentage in this group, which could be through a couple of different reasonings behind that. One could be that these patients already received treatment before the PA criteria was changed. However, there is an increase in total number of patients still. So really it's indicating that a larger percentage is going to the 18 to 34 age group. So on the next slide, we're looking at the comorbidities associated with patients receiving direct-acting antivirals. Both compensated and decompensated cirrhosis went down, or the percentage went down after changes in the PA criteria, and the percentage of those with substance use disorder did increase from 34% to over 50%, which is great. Alcohol use disorder did not really change too much, fairly similar between the two groups, as was retreatment with direct-acting antivirals. So the same number of patients were retreated, but the percentage was a lot lower just due to more patients being treated overall in the study group. All right, so our conclusions was the utilization has increased over time due to these policy revisions. There was also a clear shift towards primary care prescribing of these agents. The revisions to the criteria did allow for an increased percentage of claims for those without severe liver disease, and also an increase in percentage of those with substance use disorder as well. And overall retreatment rate with direct-acting antivirals continued to be low, less than 2% in both groups. So our recommendation is to maintain the current prioritization policy for direct-acting antivirals and continue to monitor for trends in utilization, changes in patient characteristics, and then barriers to access in the future. I'm open to questions and public comments.
This is Mark. I just had a question about measuring or monitoring for adherence to the medications. Obviously, you may fill 1 month, but if you don't fill the rest of it, it's not super likely to be impactful.
So I can kind of speak to that, Mark. As far as adherence for the fee-for-service members, all of them were required physician to attest to complying with case management. We engaged our case manager to basically engage the patients, hold their hands, and had reports of excellent compliance in adherence to the medications. Similar to the CCOs under the risk corridor, we're required to have case management. We have a couple CCOs representatives. Maybe you can talk about your experience with adherence and what you saw. But we found that members were pretty motivated when they got approved for this therapy. Shorter courses like this were well tolerated and completed therapy. So, Jim, anything to add?
No, I would completely concur. We followed this very closely at the outset. And what we observed is it is very, very rare that a patient doesn't complete the entire course. I mean, I'm speaking on the order of like 98.6 to 99.5% of the population succeeds. So I think it is due to the shorter course. It's due to their motivation. Once they engage for treatment, they have a lot of self-interest to see the treatment through. So interestingly, although we were worried that we might have areas, it just didn't manifest.
Right.
I'm really glad to know that. I was looking for that in the results. I didn't quite see it. So it's good to know. Do we also have an idea of what the cure rates have been?
I don't have accurate data on that. We're still collecting that through the risk corridor. I haven't seen completely what the SVRs. That was one thing that there wasn't a lot of as much success on, was getting those SVR 12s to find the cure rates. Anecdotally, when we did see the collections, they were very high. And there might be information that Megan might have with her literature scan to address that. And we also have one of the representatives wishing to provide public comment from Gilead, probably wearing a Jerry Garcia tie, and he might be able to address that as well.
Yeah, the only
Go ahead.
the only thing I will add is that for the purpose of this DUB, we're just because of the limitations of the claims data, we're unable to kind of get to that level of detail in the data and outcomes.
Yeah, I understand the limitations on the claims data. It's a little bit difficult. All you could really do is you could see, did they have one drawn?
Mm-hmm.
Right.
T. Martini here, one question. In the packet, it suggested that one of the recommendations was that for fee-for-service patients that had a PA denial, that there was some form of outreach that happened. And I was just curious, like, how common the denials would be and what that outreach looks like.
Yeah, so I think we did discuss that as a group about potential outreach. The numbers for, we can only see that for fee-for-service, I believe, and those numbers were pretty small in terms of the denial rates. I don't know if Sarah Served, if you remember off the top of your head what those numbers
I don't remember the exact numbers, but I do know that it was in the single digits.
Right.
Awesome. Thank you.
Great job. So Megan will... Right, go ahead.
The SVR conversion rates, if our 3 CCOs are representative of all of this effort, again, the conversion was extremely high, greater than 90%. It's been a little while since I looked at data, so I can't give you the exact quote, but it was extremely high, and Atif, Zaman, and OHSU helped us monitor it, and we were extremely happy with what we were seeing.
Great. Thank you very much. And Megan, we'll turn it over to you for the literature scan. I think that begins on 185 of the packet.
Okay, so just a brief scan to kind of go along with the policy evaluation. So the purpose is really just to search for and identify any new comparative data for the safety and effectiveness of the oral direct-acting antiviral regimens in achieving SVR and reducing long-term complications of chronic hepatitis C. And then more specifically, there have been a few new indications for pediatric populations, and so we wanted to bring those to the committee to update our PA criteria. And so there was no new comparative evidence identified that evaluated long-term efficacy and safety of these agents in chronic hepatitis C. And so I'm only going to highlight the new indications that are resulting in recommended changes to our PA criteria, which are these new pediatric indications. And so the first one, the FDA did approve Harvoni, Ladipasvir, and Sofosbuvir for pediatric patients aged 3 years to younger than 12 years without cirrhosis or with compensated cirrhosis with genotype 1, 4, 5, and 6. Prior to this, these agents were approved only for patients 12 years of age and older. And the Ladipasvir, Sofosbuvir was also approved for pediatric patients with genotype 1 with decompensated cirrhosis and genotype 1 or 4 who are liver transplant recipients without cirrhosis or compensated cirrhosis. And this approval was based on pharmacokinetic data. The third one there is Sofosbuvir in combination with Ribavirin was also FDA approved for pediatric patients aged 3 years of age and older with genotype 2 or 3. And then lastly, Velpatasvir, Sofosbuvir, Epclusa was most recently approved for children ages 6 and older with any of the 6 genotypes without cirrhosis or with compensated cirrhosis and in combination with Ribavirin for those with decompensated cirrhosis. Next slide. Overall, the data to support these new indications, it was mostly open-label data, single-arm studies with no comparator. The majority of patients were genotype 1 treatment naive without cirrhosis, but SVR rates were greater than 90% in all of the subgroups. And the most common side effects seen were similar to what we have seen in trials in adults, including headache, vomiting, and fatigue. And next slide. And that's there we go. And so based on the new pediatric indications, we are recommending just to amend our preferred regimen table and PA criteria to include these. So you can see on the next slide, the minor changes that we are bringing for the PA criteria is again to include the new pediatric indications. And so you can see in the PA criteria that starts on page 195, there are now 2 tables, one for adolescents age 12 and older and adults as well, and then another table for children less than 12 years of age, just because the table was getting too complex to try to add in all the different recommendations based on age. Next slide. And then just a couple of recommendations that were not included in the document in the packet that were brought to our attention kind of after posting. The first is for our preferred regimen table. As you can see here, if you look at the recommendation for those with decompensated cirrhosis, we have Epclusa plus Ribavirin for 12 weeks. And did come to our attention that we didn't have any language included for patients who may be Ribavirin ineligible. And so I'm just recommending that we add some language in there that for those who are Ribavirin ineligible, that they can use the 24-week duration of Softbell instead of the Ribavirin. And then the last thing I would like to bring to the committee to consider is in the approval criteria, number 4, I don't have this on the slides, but number 4, we ask for all of the pre-treatment baseline testing, including current hepatitis B status, genotype for certain patients, and then pregnancy tests in the past 30 days. And there have been some concerns that that is a big barrier in terms of the PA process is getting that pregnancy test in the past 30 days, and that has become worse during COVID. And so we are recommending that the committee consider voting to remove the requirement for a pregnancy test in the past 30 days. And with that, that, I'll take any questions.
This is Mark Helm. Just a question about the new pediatric indications. There's not as much experience with chronic hepatitis C in the pediatric population. I do not believe that in the past we've had a requirement that primary care doctors consult with a specialist on those issues. But I'm wondering if that's an appropriate thing to think about in terms of patients, particularly under the age of 12, and maybe even under the age of 18, if there should be an expectation that those patients who are treated for hepatitis C be done in consultation with a pediatric gastroenterologist.
Others' thoughts on that question?
I think it's an excellent question. It makes me wonder, though, whether we really have sentinel knowledge of risk in that age group enough to require that consultation. Yes, it's an unknown to a degree, but it's also a known because it was studied. I'm just thinking through the magnitude of what we know versus what we don't know.
Well, that's my point. There's a lot of things that we don't know. What are the impacts of this in terms of longer term in kids, and are there other considerations that we're not really aware of, given that kids are not just little adults?
Is that going to introduce a barrier to care, though, which I think especially, I think we consider it in all of our recommendations, but especially in this, I thought that there was a general consensus that we were trying to remove as many barriers as possible.
I agree. I do think that having minimum barriers, but there's a question between the barrier versus the safety, and there's not as much known in terms of treating younger patients with these agents. I also think that our pediatric specialists are becoming more and more adept at using video visits and video consultations with PCPs around the state. So it doesn't mean that they have to necessarily be seen by, but it's in consultation with.
I would appreciate any other of the providers on the committee to weigh in on their thoughts on this balancing act.
I'm curious how many, this is Russ, I'm curious how many people with this specific specialty exist in the state of Oregon, if we're going to consider asking people to consult with one of them.
Offhand, this is Pat DiMartino. I could think of at least 8 individuals, but I think the point that Jim brought up about not knowing the risk associated with it compared to the risk of potentially creating a barrier to access is something that I think I would probably put a lot of emphasis on. And I think I'm still trying to navigate exactly what the role of the P&T committee is, but I think at the end of the day, the onus is on the pediatricians to sort of evaluate their own comfort. And if they felt like they were comfortable treating a 13-year-old, I don't know if it's our place to kind of create an extra barrier.
I think it's actually not that pediatricians who are going to be the ones most likely to do this. I think it's actually be the family medicine doctors. So I think perspective from the family medicine practitioners would be more helpful.
Well, I do know that family practice has gone through ECHO training for this space and wanting a level of comfort and not just feeling like they could on their own treat, And that's not every provider, of course, but I also would ask us to observe, back to my opening remarks at our meeting today, that we're taking Hep C through a COVID-19 evolving story, and you could argue more safety put into place would help during a COVID framework. You could also argue too many procedural barriers would also hurt during a COVID-19 phase, and so it gets back to this balancing act. So I just keep throwing that up for observation. I lean personally towards not requiring it right now until we have more to act on that would suggest that there's a safety concern. That's just my own view.
This is Bill Oregon. I think in my area, most of the family docs would want some sort of consultation or assistance. I don't think very many of us, at least in the Mid-Valley, are going to embark on this without at least a phone consultation.
And this is Tracy. study, and I would see it as an additional barrier as well as a financial impact to a patient. Even if a visit is telehealth, there's still a charge generated.
Any other thoughts on that topic, or would you like to hear the public comment? All right, hearing nothing, and we can revisit this recommendation or amendment as a motion when we look at the criteria momentarily. But we do have Stuart Obrochta. Stuart is familiar to this committee from Gilead. And Stuart?
Roger, would you, can I request that you not start my time so I can answer two of the questions that were brought up that you asked that I might be able to help with?
Okay, are you wearing a Jerry Garcia tie?
You know, I'm not wearing bunny slippers like Roger and I joked about this over the phone, and we were sad that we couldn't see each other's ties. I'm actually not wearing a tie.
Okay.
As of no video.
It would have been
an extra minute bonus for you had you been wearing one.
Yeah, right. Oh, yeah. Do you want to briefly address the other parts that were brought up before I start the timer?
I will do that very quickly. So the one question that you were just discussing about peds, I have this from our medical scientist who specializes in hepatitis, that the majority, if not all, the pediatric patients are currently being treated by pediatric gastroenterologists. So it's kind of a moot point for what you bring up, even though it's a relevant point you bring up, but it's actually already directing to those providers. So not an issue. The other question you asked was SVR rates. So I can't comment for the whole class, but I can comment on Epclusa. And we have thousands of patients now in real-world evidence cohorts, and mirrors the clinical trials at 95 to 97% SVRs. So we're not seeing a difference in SVRs, even in the face of not perfect adherence, but as Jim said, these patients are invested in their care, the providers are invested in their care, and they do very well. So thank you. So I will start. So today I'm speaking on behalf of not only Gilead, but the HCV patients and providers of Oregon, as well as a representative of Gilead who does provide Epclusa and Vosevi, important, distinct HCV therapies. And I request the need to maintain open access to these on your PDL along with the other pan-genotypic PI-based therapy, Maverit. I do realize this meeting is not a full HCV class review, but I do want to share a few highlights of new data of Epclusa. And when I say Epclusa, I mean the authorized generic as well, and Vosevi. I'll start with Vosevi. It wasn't pointed out, but in your guidelines, Vosevi is the AASLD recommended NS5A retreatment regimen with the highest evidence rating by AASLD, and almost 200 patients in clinical trials achieving 98% SVR, as well as greater than 600 patients in real-world studies showing comparable results. This is currently not reflected in your PDL recommendations, and it has been brought up to both Megan and Roger's attention. I'll now focus on Epclusa, which is on your PDL, and we appreciate that. As Megan pointed out, we have a pediatric indication down to age 6, and we have a pending indication for age 3 to 6-year-olds based on clinical trial data. This is important based on the current demographic. While not reflected in your data, the epidemic, because of the PWID population or the opioid epidemic, which you've already addressed as well, being a large portion of the new infections, there are growing numbers of pediatric patients being infected prenatally because of that. For treating the PWID population, Epclusa does not have an FDA-level indication yet, but we're seeking this based on the ANCHOR and simplified studies which I've shared with you previously. Epclusa also has the highest real-world SVR for genotype 3 in F4 patients, which genotype 3 is the predominant genotype in this PWID population. One of the most important reasons to maintain Epclusa on your PDL is safety. Safety of Epclusa is the only PI genotypic, pan-genotypic HCV therapy. This is important based on the recent FDA warnings for the use of PI regimens in decompensated cirrhosis. A recent Kaiser study indicated that 15 to 20% of cirrhotics had decompensation, coupled with the fact that F3 and F4 are considered similar to most providers and child's Pew classification is sometimes somewhat arbitrary. This makes the actual patients at risk for this risk much higher than a few percent. In the current medical climate of COVID-19, safety is important, as Jim brought up. Telemedicine visits are becoming very common, and so seeing the patient and being able to assess their decompensating status is difficult. And so a PI-free regimen is very important in this era. My time's up, so in closing, I do thank you for your time and consideration of this information. I'd be happy to answer any questions.
Any questions for Stuart? All right. Thank you, Stuart.
Thank you again. I'm sorry we don't get to see each other.
Yeah, hopefully we'll be over this soon, you bet.
Yes.
So with that, we have the recommendations that Megan had put in front of you. Again, to amend the PA criteria to include the FDA-approved indications, and then the verbal change to reflect when PI-intolerant patients need Regiment. Is that captured all, Megan?
And the pregnancy test requirement.
Oh, thank you.
And then Stuart reminded me of something that I didn't specifically point out, that I did include all of the pediatric indications into the table, except, so currently sofosbuvir plus ribavirin is the only option for genotype 2 and 3 for those children ages 3 to 6. Like Stuart said, Epclusa currently is only approved for children ages 6 and older, but there are ongoing data for ages 3 to 6 for Epclusa, as well as some of the other DAA regimens that I expect to get approved soon. So because the need for ribavirin, I did not include those in the preferred regimen table for 3 to 6, with the idea just to wait till the other regimens are approved and then add it in the table.
And to that end, do we want a recommendation from the committee to amend clerically the table if and when indications are updated?
That would be great.
Yes.
Yes.
Roger, can we circle back to the conversation that Mark raised for just a moment?
Absolutely. I think we should take that first and just see if there's a motion for that addition to the criteria, and then take Megan's recommendations.
Right. I'd like to make a quick comment before we proceed with that for Mark. So I appreciate your inquisitiveness and your suggestion. And in light of the fact that we don't know for certain, we could take a vote to amend with your thoughts, and then we could just take a vote and see where we stand. Another way we could proceed would be to take a look 6 months from now and see how many of the prescriptions did not come from pediatricians, and then look into it deeper if we spotted something, given what we just heard. That would be another way to keep an eye on it.
This is Bill Erger. I would support this. I think most of my colleagues in family medicine are not going to embark on this unless they have the extra training and expertise. And right now that's uncommon. So I think leaving it open and to the judgment of the physician is also reasonable.
Well, I think that the ECHO program has done a really great job of sort of expanding people's knowledge and understanding of the treatment in these categories, and I think that's an important avenue for getting more education and experience into the hands of the prescribers.
Right.
So, Mark, would you like us to vote on your recommendation, or would you just like us to proceed with what's currently been proposed?
I don't necessarily feel that we have to have a vote about it. I think it's something that we should continue to monitor. Okay. The question about the recent pregnancy testing, I don't know if the criteria have anything in them regarding use of effective contraceptive measures or not. If that's possibly a way around that.
They do not have anything in the criteria right now about that.
So I'm hearing remove the pregnancy requirement, but include language that if a woman is of childbearing age, providers should ensure that they are on birth control?
Yeah, I think so.
Megan, could we add that to the attestation for will provider and patient comply with case management activities and ensure that women of childbearing age are on effective contraception?
We can. Does everyone agree?
I don't know that
attestation.
I don't know that you necessarily need to say that they will be on effective contraception, but I think it's important to say they will, avoid becoming pregnant.
Well, that's also something that we handle through kind of case management. As our case managers are engaging the patients, we're looking to do a full med rec to see what drugs are on, looking for interactions. That would be definitely something that could be considered, and I think it's probably most appropriate to consider it on the case management side.
Right, I agree with that.
Okay. We can share that best practice and not make any mention. Okay, so back to the recommendations. Need the P&T committee's motion to approve the recommendations as amended.
Or is it so moved?
This is Stacy, second.
Okay, then. All in favor, aye? Say aye.
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 Aye. Aye.
Anyone opposed? Motion passes.
Great.
All right. I think the secondary thing on that would be let's continue to consider DUR activities relating to the use in children.
Correct. Let's figure out a way to 6 months or an appropriate interval from now, take a look and make sure that we don't see anything concerning.
This Bill, just a general comment. I think we spend a lot of time and energy on this, and I'm very pleased that it's working and the number of people being treated is improving. Thank you all.
Yeah, I agree.
Thank you for those comments, Bill.
Right. Continuing on, we are moving, if you're following through on the packet, page 214 in the packet, sickle cell disease class review, and we'll turn it over to Kathy Centena.
Great, thank you. So the purpose of this review is to evaluate evidence for drugs used in the treatment of sickle cell disease, or I'll refer to as SCD, and also create a preferred drug list class for these therapies. As well as last year, there were 2 new therapies approved, voxelotor, brand name Oxbryta, and crizanlizumab, brand name Adaxio. So the standard pharmacological treatments for this disease include hydroxyurea, L-glutamine, and then most recently the 2 new approved drugs. Clinically meaningful outcomes we look for are stroke, sickle cell, pain crises, reduction in the need for blood transfusions, and reduction in organ damage. Additionally, hemoglobin concentrations are often measured as well to correlate with medication efficacy. However, the specific concentrations have not been, the evidence for specific concentrations have not been correlated with subsequent outcome changes. You may hear some modeling studies cited that by industry that have reported decreased risk in things such as stroke, kidney disease, pulmonary hypertension, and mortality. But this hasn't been demonstrated in a high-quality prospective outcome studies. So if we look at the evidence, there are a couple new guidelines, 3 randomized clinical trials, and then 1 systematic review and meta-analysis available for review. In general, there's a paucity of high-quality evidence for the treatments of SCD as well as treatments in general. Guidelines do recommend the use of hydroxyurea in patients with SCD for the following indications: those that have pain crises 3 or more times in a 12-month period, adults with sickle cell-related pain or sickle cell anemia that interferes with their daily activities or quality of life, those with severe recurrent acute coronary syndromes, and then infants, children, and adolescents are recommended to receive therapy regardless of disease severity to minimize complications such as delayed growth and pain crises. Looking at the evidence, continuing, there was a Cochrane systematic review that looked at hydroxyurea compared to placebo in children and adults, and they did find that it was more effective in decreasing pain related to pain crises, frequency, duration, and intensity, as well as decreasing hospital admissions, vaso-occlusive crisis, and opioid use. However, there was no mortality difference between the 2 groups. And then
Additionally, there was a randomized controlled trial with L-glutamine that was given twice daily over 48 weeks in 230 patients ranging from 5 to 58 years with SCD, and that had a history of 2 or more pain crises within the last year, plus or minus hydroxyurea therapy. The incidence of pain crises were reduced approximately by 1, so reduced to 3 in those treated with glutamine compared to 4 treated with those treated with placebo. Next, I'd like to talk to you a little bit about the new drug, voxelotor. This is a deoxygenated Sickle hemoglobin polymerization inhibitor, which binds to hemoglobin to stabilize the oxygen state. Hemoglobin polymerizes when it's deoxygenated, which results in membrane damage and cell sickling. This then releases hemoglobin into the bloodstream and blocks effective oxygen transport. Voxelotor was approved via the accelerated pathway for treatment of SCD in adult and pediatric patients 12 years of age and older. The HOPE trial served as the primary study for approval. It's a placebo-controlled double-blind randomized trial of almost 300 patients with predominantly HBsS genotype, and 65% were also taking hydroxyurea. 33% of patients who received voxelotor 900 milligrams had a hemoglobin response. So this was the primary endpoint. The hemoglobin response was defined as an increase in hemoglobin of 1 gram per deciliter or more from baseline. And then that was compared to patients in the 1,500 milligram group that experienced a 51% of those patients had a hemoglobin response, and that's compared to only 7% for the placebo group. The absolute change, when looked at, it resulted in a number needed to treat of 4 for the voxelotor 900 milligram group compared to a number needed to treat of 3 for the 1,500 milligram group, which is the FDA approved dose, and this is over a 24-week time period. I would like to mention there's insufficient evidence related to a decrease in vaso-occlusive events, how these were not different between groups. And then other markers of hemolysis, such as indirect bilirubin and reticulocyte counts, were also reduced. But again, these are surrogate markers, and we don't have a direct clinical correlation to the clinical significance of these. As a safety, common adverse events were headache, diarrhea, abdominal pain, nausea, rash, tea, and pyrexia. There's insufficient evidence on the long-term safety of voxelotor. Next, I'd like to move on to crizanlizumab. This is a selectin blocker, which is a monoclonal antibody that binds to P-selectin. So this upregulation of P-selectin in endothelial cells and platelets is associated with cell interactions involved in the vaso-occlusion and sickle cell pain crisis. Crizanlizumab was approved under the Breakthrough Therapy designation to reduce the frequency of these crises in adults and pediatric patients 16 and older. Crizanlizumab was approved based on the Phase 2 SUSTAIN trial. This was a double-blind, placebo-controlled, randomized clinical trial which looked at 2 different doses, the 2.5 milligrams per kilogram, as well as the 5 milligrams per kilogram, which is the approved dose, versus placebo. This drug is given twice in the first month and then once monthly thereafter via IV infusion. The median age in the study was 28 years, 55% were female, and 71% had the HBsS genotype. The higher dose crizanlizumab was more effective in reducing the annualized rate of sickle cell pain crises 1.63 versus 2.98 for placebo. There was no significant difference in the number of hospitalizations, and the lower 2.5 milligram dose did not demonstrate statistical significance. For the safety, this drug is associated with nausea, arthralgia, back pain, and pyrexia, and again, there's no long-term evidence, safety evidence for crizanlizumab. Next, I'd like to talk to you a little bit about the proposed PA criteria. In addition to the criteria listed in your packet, I'd also like to mention some verbal changes that will appear in red on the slides, and this is just to provide a pathway for the attainment of L-glutamine that I added here at the end. So if you look at number 1 through 3, that's standard wording. Number 4 is just directing providers to the renewal request for voxelotor, crizanlizumab, and then I'd also like to add L-glutamine to that as well. And then moving on, number 5, standard wording. Number 6 is just requesting that the patient has taken hydroxyurea or is currently taking hydroxyurea or has contraindications to it before moving on to the criteria. So if yes, if the request is for voxelotor, we're asking that the patient is 12 years and older. That's just via labeling. And then if yes, going to number 8, if the patient has a hemoglobin level of 10.5 grams or less, grams per deciliter or less, and a history of at least 1 pain crisis in the last 12 months. And if so, then approve up to 6 months and report that hemoglobin value. Next is asking if the request is for crizanlizumab and the patient, again, is 16 or older. Then go to number 10 and requesting that the patient has had at least 2 pain crises in the last 12 months. And again, approve up to 12 months if so. And then you'll see number 11 and 12 is what I've added. Just asking that if the Indari or the L-glutamine formulation is requested for patients 5 and older, that they've had at least 2 pain crises in the last 12 months. Then the next slide looks at the renewal criteria, and for number 1 for voxelotor, we're asking that the patient had a response of at least 1 gram per deciliter of hemoglobin since starting voxelotor, and if yes, approved for 12 months. For crizanlizumab, asking that the patient has a reduction in annual pain crises of at least 45%, which is what was demonstrated in the trial. And again, approved for 12 months if that's the case. And then lastly, the verbal additions for L-glutamine, that the patient has a reduction in the annual pain crisis at least 1 in the last 12 months. Again, they're based on the evidence. So at this time, are there any questions before I also believe there's some public comment?
Any questions for Kathy?
No questions.
Okay. We do have public comment.
I'm sorry, I was trying to get myself unmuted. I did have a question just in terms of the general incidence of sickle cell disease in the Medicaid population in Oregon.
In the Medicaid population in Oregon, we do have a fairly low number of them. I don't have exact annual data, but I would say low, 5 to 10.
Okay. But some of these things have previously been listed, but I think when I looked at the utilization data, there were basically no utilization.
Mm-hmm. Yeah, you're correct. It's very low.
I think we pulled some of that data. It's kind of difficult to get to that mark because we have to see a diagnosis within the claims history within a certain period of time. We can try to pull that again. I think we had kind of scoped that a while ago, but I also do not recall at this point what that number was, but I do recall it was quite low. So we do have public comment from Global Blood Therapeutics, Jamie Smutko on voxelotor. I've unmuted your line, so you have 3 minutes to address the committee, and the time is yours.
Thank you. Hi, I'm Jamie Smutko. I'm a medical science liaison with Global Blood Therapeutics. I first wanted to thank you for the opportunity to speak today about Oxbryta voxelotor tablets, a first-in-class oral hemoglobin S polymerization inhibitor indicated for the treatment of sickle cell disease in adults and pediatric patients 12 years of age and older.
This indication is approved under accelerated approval based on an increase in hemoglobin, and continued approval for this indication may be contingent upon verification and description of clinical benefit in confirmatory trials. The root cause of sickle cell disease is polymerization of hemoglobin S, which leads to sickling of red blood cells, ultimately causing red blood cell destruction or hemolysis, anemia, and occlusion of blood vessels. Oxbryta is the first approved treatment that inhibits sickle hemoglobin polymerization. This is different from historical studies focused on vaso-occlusive crises. Patients with sickle cell disease have very few treatment options for this devastating condition, and Oxbryta offers a novel therapy addressing hemolytic anemia, rapid onset of efficacy, no titration or extensive monitoring, and it can be given with or without hydroxyurea. Global Blood Therapeutics supports safe and appropriate use of Oxbryta tablets. And I'd like to propose a modification to the current renewal criteria as follows. Has the patient had an increase of hemoglobin of at least 1 gram per deciliter from baseline since starting voxelotor, or has the prescriber submitted information supporting the continued use of voxelotor? The clinical rationale for the proposed change is twofold. First, the 1 gram per deciliter hemoglobin improvement was the primary endpoint for our phase 3 HOPE study. However, achieving a hemoglobin response less than this threshold is not necessarily indicative of treatment failure. A published meta-analysis demonstrated that even small reductions of hemoglobin, less than 1 gram per deciliter, were associated with a higher risk of mortality and end organ complications, suggesting that even modest improvements in hemoglobin may confer clinical benefit. Several post-hoc analyses of the HOPE study has shown that with patients less than 1 gram per deciliter improvement in hemoglobin, still experience meaningful outcomes, such as an improvement or resolution of leg ulcers and a reduction in measures of hemolysis. The second point to support this change is around hemolysis, and hemolysis contributes to anemia and leads to end organ complications such as stroke, kidney disease, and leg ulcers. Apart from hemoglobin, laboratory markers of hemolysis were a secondary endpoint in the HOPE study. Patients taking 1,500 milligram voxelotor saw a significant reduction in indirect bilirubin and percent reticulocyte counts, which are markers of hemolysis. Given there are multiple ways to assess positive clinical response to Oxbryta, prescribers should have the opportunity to attest to clinical value based on their patient's experience. Please consider the suggested changes as disruption in therapy in these patients could be detrimental, and I thank you for your time and consideration today, and I'd be happy to answer any questions.
Thank you, Jamie. Any questions for Jamie from the committee? Make sure I'm not on mute. Great. Thank you very much for your testimony.
Thank you.
And so we did pull up some data, Sarah, you wanted to share?
Yeah, definitely. So looking at the number of patients that we had with a diagnosis of sickle cell disease, and it changes over time depending on who we have enrolled, but in 2019, we had 15 patients that were enrolled in fee-for-service that had a diagnosis of sickle cell disease based on their medical claims.
Thanks. Okay. And with that, we do have the proposed PA criteria in front of you. Well, maybe not in front of you, but the recommendation tabled.
And that is on page 231 in your packet without the verbal additions, if you're following along that way.
Any discussion about what's proposed?
This is Pat DiMartino. To recap, the verbal additions were just the glutamine stuff?
Exactly. Yep.
So if there's no other questions or thoughts about making changes, the recommendation would be to approve the PA criteria as proposed and amended.
Pat DiMartino, the motion to approve.
Second. Second.
All in favor?
Aye. Aye. Aye.
Aye.
I'm not sure I heard all the ayes out there.
Aye.
Okay. Anybody opposed? Okay, motion passes. Great, thank you. Proposed just logistic check. We do one more class, the drugs of Duchenne muscular dystrophy, and we also have some public comment with this, and then we take a break. Is the committee okay if we do one more class before taking a 10-minute break?
Okay.
I'm okay.
Fantastic. So we'll turn it back over to Sarah Servant, drugs for DMD.
Thanks. So the purpose of this review is to look for new comparative evidence for drugs for Duchenne's muscular dystrophy, or DMD, and evaluate placement therapy for a new drug called golodosin. Just a little bit of background, DMD is a rare X-linked genetic disorder that's caused by an absence of functional dystrophin protein. Patients with DMD experience progressive muscle deterioration, leading to loss of ambulation and decreased muscle strength. There's currently no curative treatment for DMD, and therapies focus on improving symptoms, enhancing quality of life, and decreasing disease progression. Current guidelines recommend initiation of corticosteroids as a first-line treatment for ambulatory children with a decline in motor function in order to delay loss of ambulation, preserve pulmonary function, and reduce the risk of scoliosis. We have previously evaluated both deflazacort and eteplirsen, which are indicated for DMD. So the summary of that evidence is located here. Prior authorization is currently required for both those drugs to ensure medically appropriate use. Prednisone, which is the other corticosteroid that's typically used for DMD, is available without PA. Since the last review, there's no new comparative evidence on efficacy or safety data for either eteplirsen or deflazacort, and the required post-marketing study to verify and describe the clinical efficacy of eteplirsen has not yet been completed. So looking at the evidence for golodosin, it was approved in 2019 for patients with mutations that are amenable to exon 53 skipping, and the goal of this therapy is to modify the mRNA splicing and increase the amount of dystrophin protein in cells. The golodosin was approved based on an ongoing single-arm, open-label phase 1 and 2 trial based on the surrogate marker of dystrophin protein. Currently, data only for the biological outcomes of dystrophin at 48 weeks are published. They were evaluating efficacy outcomes as part of this trial as well, but collection of these outcomes was ongoing at the time of FDA approval. So compared to baseline, patients who were treated with golodosin demonstrated a small improvement in dystrophin protein over 48 weeks, so a change of 0.9% of normal compared to baseline, and there's insufficient evidence that use of golodosin has any impact on symptoms, muscle or pulmonary function, quality of life, or disease progression. The FDA review of golodosin safety included data from 2 ongoing studies, and at this time there's insufficient evidence regarding long-term safety. The FDA labeling does include warnings for hypersensitivity reactions and renal adverse events, so renal monitoring, including a 24-hour urine collection, proteinuria, and serum cystatin C is recommended as part of the FDA label for golodosin. So the proposed PA criteria changes are outlined in the packet. The major changes are also listed here. So the first is addition of a table for FDA-approved indications for exon skipping therapy to outline examples of amenable mutations and specific mutations for exon 51 skipping for eteplirsen and exon 53 skipping for golodosin. The second modification is to modify the question 4 in the criteria to specify that all therapies, if it's continuation of therapy, and this should specifically be fee-for-service approvals that have been previously approved through fee-for-service, to direct those to the renewal criteria of continuation of therapy. The second modification in question 9, referencing that table 1 if the request is for an FDA-approved indication. 10 and 11 add golodosin to the criteria and the required monitoring according to the label, including that 24-hour urine collection. A slight modification in question 12 to add language regarding contraindications to steroids. So currently corticosteroids, since they are recommended as first-line therapy, the patient should have tried those or had contraindications to steroids. And then as part of the renewal criteria, again, questions 1 and 2 are adding golodosin to the criteria and recommended monitoring for renal function. And then questions 4 through 5 are asking for an assessment of any serious adverse events related to treatment and if the provider has submitted those to the FDA adverse events reporting. Any questions on the recommendations or the evidence?
That must mean well done. Great. We do have some public comment. First up, we have Dr. Erica Benanger. Sorry. Let me find your line and unmute you. And Dr. Benanger works at OHSU, pediatric neurologist. She's testified in front of the committee before. She's not here on behalf of an advocacy organization or at the request of industry, but she does disclose on her COA disclosure that she does receive grants and funding, and that she's also been involved in research. So didn't know if any committee had any questions about conflicts before we turn the table over to her. Great. Hearing none, Dr. Benanger, you got your 3 minutes.
Thank you. Thank you again. This is a new setting to be meeting, but we have met before. Again, I am from OHSU and take care of a large number of patients with Duchenne muscular dystrophy there and at the Shriners Hospital. I guess, mostly just brief comments about the criteria as recommended or reviewed today. First and foremost, I think the newest medication added here, the golodirsen, obviously comes with additional monitoring as is detailed in the approval criteria here with regards to renal monitoring. Just to, my ask, I guess, is that perhaps some clinician individualization be given, just because monitoring for glomerular or renal function in these children is very difficult. They do not have an accurate creatinine, and so that's part of the reason that the additional, much more onerous measures were put in place. And in my discussions with our pediatric nephrologists here at OHSU, I don't know that they feel that the recommended monitoring as per the label in the FDA is actually the best way to truly monitor. And so I think giving some degree of clinician control over what's the best way to monitor this would be helpful for me, rather than doing a test that I don't think is actually a good indicator of renal function, potentially. The other thing that I would just bring attention, as we've talked before, is that being somewhat general about the assessment for functional outcomes after treatment with these diseases, with these drugs, because different ages, again, the study, the label does not limit what age is treated, and we use different objective measures depending upon the functional level of each individual patient. And so, for example, the 6-minute walk test is not appropriate for all patients. And so 6-minute walk and North Star, I think, were included, but there's a wider range of different outcome measures that are administered by our therapist that are appropriate and chosen based on the functional status of the patient. So some further clarification that an appropriate test could be followed is what I would suggest. That's all I have.
Thank you for your thoughts. Do we have a motion by anybody to amend based on that input?
Let's go over. So how do you measure renal function in these kids whose creatinine production is abnormal?
So that's the using the guidance of my nephrologist, who I trust. So they have recommended using cystatin C, which I know is part of the criteria as well, but they rely more heavily on that. A 24-hour urine can be done, but that's typically, it's pretty hard for kids, particularly those who are in a wheelchair, to do this test. And so we absolutely would do it if it was necessary, but usually they are able to do repeated quantitative proteins. If those are elevated, then pursue 24-hour urine. But in reality, if I had any concern whatsoever, I'd be working with my nephrologist to figure out how best to assess this over time. So they're all appropriate tests. It's just I don't know that being as exact about which order to go in rather than allowing the nephrologist to really decide what to do. But having a baseline Cystatin C is important. I think getting a baseline 24-hour urine is reasonable, but there's a lot of variability in those measures. We know this from the studies. So we participated in all of the exon skipping studies, and we see a lot of variability. There's going to be a lot of testing for these kids if given the current criteria. And again, we want to do it safely, but I also don't want to over-test in something that we know is significantly variable, and at least our experience in the trial would tell you it's going to be abnormal and then resolve on its own spontaneously frequently.
Thank you. This is Mark Helm. The question that I had would be sort of what would be the other kinds of functional assessments that would be useful. To me, the question on these kids is always lung function, but that's never addressed. And I haven't seen any information from Exondys 51 that there has any impact on the changes in pulmonary function over time. Maybe you can clarify some of that.
Sure, that's great. That's a great point. And obviously those are very important outcomes. So for our older kids, pulmonary function is a really good outcome measure. Typically, it's not measurable until about age 5, and then, of course, even in boys who are affected with Duchenne, it is actually going up, not at a normal rate, but is improving. Once children become non-ambulatory, it does start to decline. And so it is something I would advocate using in our older kids, for sure. It's a great outcome measure. It's obviously an important function we're trying to monitor. And there is a study on eteplirsen. It's not, I shouldn't say it's a study. There is a paper that's published on eteplirsen looking at lung function over time from the very original study. We do not have any data for golodirsen as of yet. I can find the reference for that if that would be helpful and share it as well.
Well, I think I was just looking to have some other things that could be added to the renewal criteria in terms of, other than just simply looking at a 6-minute walk test.
Yeah, well, that's exactly what I would advocate. So roughly from that paper, what we saw is that the PFTs declined about half as fast as natural history, and that wasn't compared to a placebo. So again, there are limitations in that data, but it does appear that there is an effect on lung function over time. The North Star is a great outcome measure for younger kids. Sometimes they can't even participate with all of that, so even a 10-meter walk-run sometimes we use by itself, or a 4-stair climb, which are part of the North Star. And then there are other measures later on that are also helpful, upper extremity measures and things like that are very well validated in this population and are an important part of what we follow over time. So again, it's just these are two great tests, but there's a larger group of tests that we use. I'm not sure the exhaustive list, but I'm not sure how to make it a more general criteria that would include, as you say, PFTs and other things as well.
Well, I mean, we do have two that are specifically listed and have et cetera.
Good, and that's fine with me as long as my comment is just sometimes things are held very strictly. I think it depends on who's interpreting the criteria. So I like the et cetera. I can live with et cetera.
It does make me wonder whether what we're really looking for in renewal is for the treating provider to provide objective monitoring data that suggests that the patient is, justified continuing to be on therapy, right? Mm-hmm. And you may pick different things depending on what you're using and what is relevant to that, but it seems like that's the heart of it.
Correct. And I typically also then explain it, obviously, to why what's different, why we're following this, and why I'm asking for a renewal.
I think it's challenging to figure out. This has a very marginal impact on the presence of dystrophin, and that's the only thing that we really know. How do you determine who should and shouldn't continue? And do you ever determine that someone shouldn't continue?
So I think that's a great question, obviously. I think, obviously, if someone were to have adverse events related to it, it is a fairly intense regimen with getting IVs every week. And so I think I have not had anybody discontinue in the study, even in a prolonged open label period. So I think families are very committed to doing this, and it's also very safe. So I haven't had people stop because of safety issues for any of these two drugs or the other exon skipping drug that we also have in trials. I think that it always is a risk-benefit comparison for you with the family, and sort of I think at some point that level becomes the risk or the intervention becomes more than the potential benefit. So part of it is a discussion with the family with their weighing of those criteria. But this is a disease that changes slowly, and what we're hoping with this, obviously, as you said, with a low level of dystrophin, is that we are slowing the progression of the disease, as we do with steroids. And any slowing of this is something that we would advocate as significant benefit, because as that translates over the longer period of time and over the person's lifetime, is how we have to look at it. So it's hard to look from 6 months to 6 months on a renewal and really show that change.
So to see, kind of elaborating on that, would you expect, or is it a potential to see certain patients that don't show that prevention of decline and decline fast enough that it's clear the therapy is not working?
I think that's hard to do on an individual basis as of right now, because there's variability in this disease. Even though we have good natural history study and data that we can compare it to, I think you have to look over a longer period of time in an individual to say, are you falling outside of the range of natural history, or have you had enough benefit that you are exceeding what we would expect within the range of natural history?
And then how long would you have to go to kind of get to that place where you could potentially look for that?
I mean, based on clinical studies, and really, again, they've done more of the statistical analysis of this. The more recent studies have been designed with a 2-year placebo period for this reason.
But the separation between what's sort of the untreated group and the treated group should happen much sooner than 2 years.
Okay.
Do you disagree?
I don't. I think that's hard to say. I think that there's variability in the disease, and these measures aren't changing all that fast over a period of time. Now, they are, if you're in the active decline phase, some of them are changing such that you could be able to detect that in a shorter period of time. But I think most studies are extending beyond a year, not specifically for exon skipping, but for the other trials we're involved with as well. The read-through therapy is a 2-year placebo-controlled trial. Another trial is at 15 months. So I think in general, at least a year is what we have learned from all of our previous trials is what we need in order to detect that difference.
So carrying this logic out, just coming back to what we're looking for renewal consideration, would it be useful then to, I know that you would use a constellation of things to monitor the patient, as we just discussed, right? But if you're trying to do, let's assume it's 2 years from now, an objective view of how much they've declined or not declined in their pattern of, wouldn't certain approaches be better to be consistently done across the entire course of monitoring to give you that better objective view? Or, I mean, help us think through that a little bit, right? Because I think what we're trying to figure out is what to make sure is there in such a way that both you as a provider and us as a person in charge, a system in charge of monitoring it can make an objective view of what's going on. Does that make sense?
I think so. I think you're asking me should we be using certain measures that we then can see over that longer period of time? Is that primarily? And it depends on where the child is entering into it. So we more and more are using these measures as a routine part of our clinical visits with the subjects. So one thing is, as they come in for their routine care, we may have preceding, before they went on therapy, numbers to compare to. So that would be an ideal situation. Again, oftentimes younger children can't participate with these measures. So the North Star, maybe a 4-year-old can participate with. It's really well performed in a 5-year-old. So we're not going to have a lot of data from before that period of time to compare to. It is very good for a large number of years until the child really begins to lose ambulation, at which point the North Star, most of the features on that test are going upstairs and rising from the floor and things that are not going to be possible as they get later into their stage of disease. So I think, and then the 6-minute walk likewise starts at about 6, and maybe I like the North Star a little bit better. It has more different aspects to it. It's quicker. The kids enjoy it more than they do the 6-minute walk. But they both are about the same time period. If you get into the older, we can start using the upper limb measures before children lose ambulation, and then they transition over the rest of their lifetime, essentially. PFTs are just hard because of the natural history in the early younger kids, though we can perform them in 5-year-olds. There's a lot of variability as those numbers increase. To show improvement in a score that's increasing is going to be more difficult. When they start to decline, obviously, then it is something that we have a good idea of what the natural progression is. So I think using a multiple, we don't ever pick one. In general, we try to use 2 to 3, and part of that is comparison to where we are, but also comparison to where we will be going in their stage of disease, and therefore we can watch that, over time. We don't abruptly switch from one to the other. We try to have crossover and redundancy.
Right. So can we bring back up the criteria?
Pat Martino here. It sounds like perhaps there isn't going to be like a great aggregation of metrics to use, whether it's a 6-month or a 2-year interval. And I don't know, as a committee, do we ever account for these conditional approvals where, in theory, there are trials ongoing that are looking for clinical outcomes, and sort of using that to justify more lax renewal criteria?
I think what this conversation reminds me of is some of the times of space that we'll find ourselves in oncology, in which, depending on the circumstance, you're asking the provider to provide at the outset of treatment an objective framework to reevaluate the patient for ongoing treatment, and then you reach that interval and you refer back to that plan, and then you look to see what's provided. You know what I mean? So that there's a follow through, and there's some organizational structure to the ongoing evaluation of whether the therapy is continuing to earn itself in the individual. And families play an incredibly important role, but that's not only the piece of the puzzle, right, in terms of objective use of clinical care. So there's something in there about that I think might be appropriate.
Yeah, this is really challenging. This medication, or these 2 medications, are really challenging, from the perspective of how they were approved through the FDA. They were really approved without, the only evidence that they have is that it changes the percentage of dystrophin protein that you can detect from, very, very, very low to very, very low.
Yeah, I would agree with that. This is Bill Oregon. So far, the data we have shows no clinical benefit for this drug.
And that's the risk of the accelerated approval process, and particularly with the politics that got involved in the approval of exon 51 anyway, which I assume applies to the exon skipping 53 drug.
Yes, but we've been through this in the sense that we are required to cover it, but we can cover it with criteria.
Understand, and that's the question that I have is like, well, what is the criteria? If the criteria
that's the challenge, but we still have to kind of partner together for some objective process here.
I think so too. I'm an advocate for that. I really think that lung function testing is kind of the key, because that's it's the respiratory failure that is the key component here. It's not so much ambulatory or non-ambulatory.
So using a combined approach, the idea of asking for some standard objective measurement of stability, I think that's about all we can do. there isn't much evidence of that. And we have to base it on evidence.
Well, yeah, but that's the point I was trying to get to earlier, which is basically with these patients that are on treatment, we're basically creating a study, an observation over time, right? Yeah. And so how do you set a reasonably common framework in order to pull that off on an individual basis or a group basis? That's really the question, because that's what we're doing.
Mm-hmm. And I think that's where expert opinion can help us. And we've gotten some ideas here that I think fit with, Jim, what you said about some sort of standard objective measurement, both for safety and efficacy.
I'd almost be inclined to recommend we approve the policy as is, with the exception of the not being quite specific on the test as it was originally suggested, but then we take this offline and see if, with the observational study concept, if something could be firmed up in the way of a recommendation with a little bit more back and forth that I don't think we're going to solve in the committee.
Good idea.
I agree. So we do have one more public comment. Any final questions for Dr. Benanger?
Thank you.
Thank you.
Great. Thank you. So we also have Lisa Borland. Lisa's with Sarepta Therapeutics. And Lisa, you have 3 minutes with the committee, or more if they have questions for you.
Okay, thank you, Roger, and good afternoon, everyone. I'm Lisa Borland. I'm a Senior Director within Medical Affairs at Sarepta Therapeutics. I don't have a prepared testimony. I did want to address some of the comments and questions that came up during the discussion. First is around accelerated approval, and the discussion around the approval. As we all know, the intent of the accelerated approval pathway is to bring novel therapies to patients with serious and life-threatening conditions where there are no other options. And so there's no other disease that really fits that criteria, like Duchenne muscular dystrophy. And so that underlying dystrophin, which absence is what is the underlying cause. These exon-skipping therapies really target the lack of dystrophin. And there's also been some discussion around the confirmatory studies, and we know that as part of the accelerated approval pathway that confirmatory studies are required to confirm clinical benefit. That is applicable to all accelerated approval therapies. It is not unique to eteplirsen and golodirsen. Those confirmatory studies are ongoing for both eteplirsen and golodirsen. And I do want to emphasize that outside of those confirmatory studies, Sarepta is committed to generating long-term therapy. So long-term outcomes and long-term data to help support this. We realize how, even in just these discussions, how difficult some of the decision-making is, and we want to provide you with as much data as possible. So with that being said, I want to go back and kind of expand on the discussion around lung function. And Dr. Helm, you had mentioned that you hadn't seen any data around lung function. I will point out in the references that the DERM has created for this drug class review, there are two references there, Canane and Kahn. Those are the pulmonary function publications. I would say that the Kahn publication that's listed as number 11 is the one that is more comprehensive in that it has data around a broader group of DMD patients, both ambulatory as well as non-ambulatory patients. And as Dr. Benanger stated, really what the evidence shows is that treatment with eteplirsen leads to a decline in pulmonary function at half the rate that would be expected from natural history. So the comparator there is a large natural history cohort. I will also say that there is 4-year ambulatory data for eteplirsen, which kind of speaks to what was discussed earlier around when we start to see the clinical benefit. And really where we saw the divergence of the line between eteplirsen treatment and natural history was after 1 year of therapy. And so that is consistent with the previous discussion. And then around golodirsen, I do want to say that we have safety and efficacy data was obviously evaluated in the 101 study up to 144 weeks. And we look forward to presenting that in a public forum in the very near future. And I'm happy to address any additional questions.
Any questions?
So I do. So with the ongoing studies that you referenced, because you are required to do them, is there anything there in that framework that could help us with this discussion that we had earlier and what to track?
Yeah, so I'd say that for many of these exon skipping therapies or Duchenne drugs, you're going to find the same types of outcomes. So the primary endpoint for those studies is also a 6-minute walk test, and secondary outcomes include pulmonary function, the North Star ambulatory assessment. So all of the functional assessments that were previously discussed and that Dr. Benanger mentioned that she utilizes in the clinic are some of the measures that were utilized in the clinical trials, including FDC % predicted, so pulmonary function as well.
Okay, so then 6-minute pulmonary function and North Star seem to be some core ones. Obviously, depending on age, as we heard, there may be some variation, but that could be expressed in responding to the criteria. So I just wonder if we're honing what to track, and again, we can take this offline and make sure we get it right, but it feels like we shouldn't deviate too far from the core.
And I would just also say, I think just to having, as was discussed before, having a broad range of assessments, because it does depend on where the child is in their disease progression, and that the 6-minute walk test is not conducted in all settings. Not all children can do it. So there are a lot of factors that need to be considered. So greatly appreciate the fact that the committee is considering a broad range that could be applicable and individualized.
Right. Well, so you could say, we can do pulmonary function and we can do North Star, but we can't do 6 minutes, so we're going to do this instead. That wasn't completely accurate, but you see where I'm going. Like, it would still provide here's a normal range of core things to track, and then you could respond in the PA criteria, well, we can't do this one because of the setting or situation, we're going to do this instead.
There's one misconception that I'd like to comment on, Ms. Benanger. True, there has been no specific therapy for Duchenne muscular dystrophy, and this novel therapy is very fascinating and very clever. However, general supportive care has increased the lifespan of patients with muscular dystrophy by about a decade over the past decade. So they are living longer in the absence of a specific therapy. And I think we need to put that in part of our perspective as comparing this to quote-unquote standard treatment.
And corticosteroids are a key component for helping reduce progression as well.
I would add there, this is Lisa again, that any of the benefits, so any of the pulmonary function benefit, the ambulatory benefit that has been seen in these longer-term eteplirsen trials has been on top of standard of care and steroid use. So all of those patients in the clinical trials, at least in the ambulatory studies, were required to be on corticosteroids.
But we have an RPA criteria, that they could not be on corticosteroids if there's some sort of a contraindication to it.
Yeah, I guess my point was that the benefit was seen on top of corticosteroids, and what just in reference to the previous comment.
Overall, learning together the duration of the treatment effectiveness over time, or we wouldn't be having quite this discussion. It's still an unfolding story, clearly, which it could be excellent, but it could also be not as good as everybody had hoped. We just need to find out.
So what's the motion we have in front of us?
So if we can pull up the criteria again, I was motioning initially that we would follow through with the existing criteria proposal, with the exception of modifying the wording so that it provided right now for not be quite so specific in the order of the testing, if I recall correctly. Where does that show up?
Thank you, Lisa.
Number 13 there.
Yeah, the criteria that we have in front regarding assessment of functional outcomes is in question 13. Ask if initially, upon the initial approval, if baseline functional outcomes have been evaluated using a validated tool, and then it lists some examples. And then in the renewal criteria, question 3, if the baseline functional status has been maintained at or above the baseline level or not declined more than expected given the natural disease progression.
So basically what we'd be saying then is the treating provider would have to provide a validated tool as part of the documentation. And if they did, whatever tool was appropriate for that particular age and patient circumstance, then that would be expected in a renewal process unless there was some excellent reason as part of the renewal requirement of how they performed in that validated tool. And of course, the treating provider could elaborate beyond that specific test because you're using a variety of ways to monitor their function and their ongoing treatment effect to expand on the story. But it seems like that seems appropriate, right? That we would have a validated tool as part of this process. So it doesn't feel like to me that, in reading it again, it doesn't feel like that to me is overly prescriptive.
Agree.
I would agree. Yeah.
I think we're okay.
I think so too.
Meanwhile, if we can take this offline and find any other wisdom here about, given that this is an important investment in patient care in an accelerated manner,
absolutely,
I think that would be extraordinarily appreciated.
Yes.
Okay. So the recommendation in front of the committee is to update the PA criteria for DMD as proposed. And again, were there any amendments, Sarah?
No amendments.
Okay.
I would make that motion.
Second.
Okay, then, all in favor?
Aye. Aye. Aye.
Any opposed? All right, motion approved, and we really appreciate the input that we received today, and we will continue to work on this outside of the P&T meeting to make sure that we get this right.
Great. So again, it's the committee, just so we don't have any noises we don't want on the phone. Let's take a 10-minute quick break in case people need to use the restrooms. I'll start the clock. All right. So we've got about 10 minutes of break time. I hope that was sufficient for everybody. Still have a fair bit of agenda to get through.
Roger, before we proceed, I'd like to make a chair comment, if I could.
No, we're too far behind, Jim. You can't say anything. Of course. Go right ahead.
I just reflected on the conversation we just had, and I think this is an excellent use case. And I just would like to call out that in the case of accelerated improvement, it increases, does not decrease the vigilance that we all need to play in determining evidence-based outcomes. And so despite the fact that we find ourselves in this complex process with these patients with this therapy and different ways to monitor, it necessitates between the drug company, between the studies, between us, to figure out ways to objectively monitor these patients, even if they have to be used as their own control, so that, A, it accurately will feed into the drug company's assessment process that they talked about, where they're going to reassess the overall effectiveness. And I know the providers would do that, but we need to understand what that is that they will be evaluating specifically, and then B, that we have more an objective way to play our role in monitoring patient care and outcomes as they come up for renewal. And that's a mandate. And so I do really want us to work offline towards those objectives and to use this as a use case to learn how to do this with accelerated improvement approved drugs. So I'm getting a little cranky, but I think it's so important that we push through on these topics.
No, appreciate it. Thank you for that. Anybody else want to comment or add to Jim's comments before we start with the next topic?
Pat here. I have not been here long, but I would imagine this is an especially challenging approval in that the outcome with which it was approved on is just so distant from anything measured in the clinic or mean anything to a patient, which maybe adds to the complexity of what we need to follow to sort of ensure good utilization.
Yeah, that's absolutely right. I mean, it's quite a challenge, isn't it? Okay, I'm going to assume that we have the committee back. We'll certainly find out when we get going and we have our first vote, but I'm going to turn it over now to Sarah Fletcher for a dose consolidation proposal. If you're following along in the packet and not online, if you're just on the phone, but looking at the packet that's posted online, we're on page 250.
Thanks, Roger. I will try to make this brief, as I know we're short on time, but I'm here to present a dose consolidation proposal that we have, and just the introduction. Antipsychotics, because of the carve-out, are consistently one of the highest areas of budgeted costs. But in looking at these, many of the products have a fixed or flat price across the range of dosage strengths. And so occasionally what happens is patients are slowly titrated up from the initial dose to their maintenance dose, and they end up taking multiple tablets per day rather than a large one single dose. And so the goal for this proposal is cost savings as well as a reduction in tablet burden. And so here on this slide, you can see this is the fourth quarter of 2019 and its gross costs. 3 of the top 5 medications in the fee-for-service are oral antipsychotic medications. You can see Latuda has a gross cost of almost $6 million, and both Vraylar and Rexulti are over $1 million each for that quarter. And so that accounts for a huge amount of our expenditures. So next slide. So this is what I mean by a fixed dose or flat priced medication. Latuda has a dosage range from 20 to 120 milligrams, and the 20 through 80 tablets each have an average actual acquisition cost of roughly $41. So if someone takes 40 milligrams times 2 tablets, it's double the cost of taking one 80 milligram tablet. So for the next slide, you can see that Vraylar is exactly the same across its dosage range of 1.5 to 6 milligrams. All of the tablets cost roughly $39 each. And then the next slide, Rexulti is the same. So it has a dosage range of 0.5 to 4 milligrams. You can see the indications and usual dosage at the bottom. And so patients can end up taking as much as 4 milligrams per day, but it would be a lot more if they're taking something other than a 4 milligram tablet. So with the next slide, what our proposal is to implement a pharmacy edit to consolidate the medications that have flat pricing across the various strengths. And this procedure would be twofold, and we've already actually implemented the first part, which is to send letters to prescribers on the specific patients that this applies to. And so we've already hopefully realized some of the cost savings from that. But what we're proposing here today, and what I'm here to get your comments on, is a point-of-sale edit at the pharmacy level. And so what we're proposing to do is have a quantity limit of 2 tabs per day or 1.7 tabs per day as the average daily dose across the prescription, flag at the pharmacy. And the reason we would have it as higher than 1 would be to allow some titration, but the pharmacist will receive a message and request them to basically consolidate the dose to the highest dosage tablet. And if there was a reason that it needed to be multiple tablets, like it was too hard to swallow a big tablet, or they're actually titrating and we didn't catch that, it can be overridden with a phone call to DXC without having to bring the prescriber into it or call the office and spend time in that way. And the proposal that we're talking about does not apply to different pharmacokinetic drug formulations. So we would not be changing an extended release tablet to an immediate release tablet. These would only be flat price drugs across with similar pharmacokinetics. So the next slide, this is based off of actually first quarter 2019 net cost. And you can see that there were only about 200 patients for these 3 drugs that this applied to. But if we could change them all to a consolidated dose, the net savings would be roughly $300,000 per year. And so it's not very many patients that actually need this changed, but it could be significant cost savings. And there are other medications in addition to these 3 that this could apply to. So the next slide. I took this proposal because a lot of the medications that this applies to are carve-out medications. I took it to the MCAT group back in January or February, and some feedback, and so these are just some concerns and then our mitigation strategies as concerns that they had written. I'll just go through them one by one.
First was how the MD received notification of the dosage change so that they can make sure that their medication list is up to date. And when a retail pharmacist makes a change, they're legally required to notify the prescriber. So there would be a fax associated with that. How the patient be counseled in case the physician had instructed the patient that they'd be on 2 tablets. If it's changed to 1, that could lead to a dosing error. And so the dispensing pharmacist, that's another part of Oregon law, they're required to offer counseling, and a patient declining must do so to the pharmacist directly, not to another staff member or a technician. And then how do we identify appropriate patients or exclude them during taper? And I mentioned that, but we would try to set the edit to only flag if it's like 1.75 tablets per day or 2 tablets per day, rather than something just over 1. That way there's a little bit of wiggle room for tablets as they increase over time. And the last slide are just a few more concerns and mitigation strategies. One was a question about if a patient was receiving a medication at a dosage interval that was different than the manufacturer-approved dosage. The example being giving it BID when it's really just a Q-day drug, which we know sometimes in psychiatry can happen, particularly for side effects. Would that change at the pharmacist level? And because it's a change in dosage schedule for this particular proposal, that should not change. So that should not be consolidated. And then the follow-up question was, what if it's intentionally being given that way? Are they going to call the prescriber? And for this particular edit, that's not a requirement, but a pharmacist could use their clinical opinion and make that call, which is okay, but it could result in a few calls, but it could result in those phone calls independent of this pharmacy proposal. And then lastly, just as another kind of safety net thing, is that with this proposal, we want to initiate a retrospective fax so that if there was a patient who had a denied claim because of this edit, but then did not get a paid claim for either the original dose or the consolidated dose, that would automate a fax to the pharmacy to recommend consolidation or give them this information on how to override it through DXC to make sure that the patient does not miss a prescription. So that's the essence of this program, and we would be changing, or we would like to be able to adjust which medications it applies to just based off of how prices and whatnot change. But that's the essence of it. Are there any questions or comments I can take?
This is Kathy. Hi. So a couple questions. How's the pharmacy processing this going to realize that they don't have to call the provider? I mean, my first gut reaction when I get that, I'm going to say, well, I do need to reach out to the doctor. How do you know for sure that this is what is supposed to happen?
So our intent was to, as part of the rejection on their level, was to have some wording in there for what to do, as well as because it's so few patients, we're going to be faxing the pharmacies before implementing this edit on site with the hope that they would also be able to see what it is that they're supposed to do and that it's not rejecting it for a reason that they can't fix. Because this is something they can also do independent of our program. Like if there's a drug shortage and they need to change the tablet sizes, this isn't something that should necessarily result in a phone call to the physician.
Okay. My question was similar to that, except it was sort of a different orientation. We have a small number of patients who account for a very large number of these instances. Did we look at the number of prescribers that were associated with those patients? Were they all like from individual different prescribers, or is there like 1 or 2 prescribers who tend to prefer these smaller doses, more frequent administration?
Oh, goodness. I do not remember that specifically. I want to say that they were over a wide range of places, like the pharmacies were a number of different pharmacies, and so I don't think it was coming out of one particular practice, but I don't recall from when I pulled the data exactly that, but I don't think it was something that simple. And we would be not just these medications, but there would be other ones we would like to implement this on as less time goes by as we identify them.
Sure, and I think this is a really good idea. One thing that I think would be useful in terms of the safety net facts, while you're talking about sending that to the pharmacy, I think it would be also useful to send it to the prescriber as well.
Okay. And when we did implement this, that was the first phase of the implementation, as we actually sent these faxes directly to the prescribers that were involved with these patients to hopefully avoid it getting to the pharmacy level, and that we've actually already done.
So when you give the feedback to the provider, are you telling them to edit their med list so that med list is updated so there's no confusion about number of tablets and dosage and actually what the patient's on?
Sorry, this is Russ. That's a really important point, too, because if I just refill from my med list, it's going to be the prescription.
Right. Hi, this is Stacy. I think that's the point of the facts from the pharmacy, though, right? So it might be helpful to develop some type of a form letter that says, we're not changing the prescription, we simply consolidated doses, but in an effort to keep medical records clean, it would be great if you would update their chart so that the next time we request a refill, it will be for this consolidated dose. So when you fax the pharmacies, faxing them, I know you've done this in past, faxing them like a form letter that they can then send to the provider, that would be really helpful.
Okay. Yes.
And then one other suggestion on this. Sorry, my dog is getting ready to bark because there's a car pulling up, so I will warn you all. Oh, maybe not. Maybe she's not going to do it. And I've completely lost my train of thought with that, so I'll pass it on, and if it comes back to me, I will come back on the line.
Okay, thanks. Sometimes with the electronic refill requests, it will come through with whatever the medication that was dispensed was, but I don't think that that's always necessarily consistently done. The other question I have on this is, did you look at this, in terms of like, well, what if you used 1.5 tablets per day instead of 1.75, or what if you used 1.25? All of the medications in this particular category are once daily medicines.
Mm-hmm. Yes, the 1.25 or 1.5, that would be if someone got a prescription for one tablet daily for 2 weeks and then increased to 2 tablets daily, so that the average daily dose would be over that. And we were trying to get closer to 2 in case they were on a taper like that. Did that answer that question?
Well, I think so, but, in a situation like that, I think I would rather give them, I would say, half tablet for, 2 weeks and then increase to a full tablet.
Mm-hmm.
You can't split most of these.
Yeah.
Right, didn't say can or cannot.
Cannot.
Yeah.
Can I jump in for a sec? This is Rich. This optimization point of sale is something we do in 5 of our states already. We're kind of mimicking this after Connecticut, Wisconsin, where they don't have, in Connecticut there's no managed care, so they do this on about 200 different drugs across physical and mental health. And they kind of the rules are, once daily dosing drugs and no mandating or requesting or asking any half tablet or pill splitting of any kind. Just whole tablets only.
And for this, I know we're also working on the dose optimization from the DX side. This would be slightly different because I think we would be cherry picking the medications that we thought have higher risk if something went wrong in the filling process, and so we wanted to manage it a little bit more closely. Roger, correct me if I'm wrong on this.
Nope, spot on.
Well, given what you just said, it makes me wonder, and given the small number, it really makes me wonder whether this shouldn't be more of an order change form process that does go to the provider, rather than the other way around.
Well, and then Sarah mentioned at the top of the order, we've been doing that, and we haven't got a lot of traction. So
that's why I was wondering, we'll probably be more responsive maybe than, because that will happen right then and there for dispensing.
Okay, it'll be interesting to watch.
Lag time.
You may get action, but you also may get confusion and lack of documentation on the EMR side. So it's going to be interesting to try it the other way around.
That's why I was, sorry, this was
the EMR.
Yeah, suggesting that some sort of communication go from the pharmacy to the prescriber so that the EMR gets updated. I remember the other thing I was going to suggest. So in the communication that goes out to the pharmacy, I think that, again, most pharmacists should know that there are a lot out there that I know I still get calls from pharmacies saying, is it okay to change 250 milligram tablets to 100 milligram tablets? So just a reminder that this is fine. You don't have to wait for the doctor. You're not going to get a call back. You don't have to call them and ask them to do this. You're going to do this, and then you're going to let them know, hey, I've consolidated these doses, so can you please update your record? So I think just clarification will help everyone. Will make that process so much smoother all the way around.
Okay. And then we did also confirm with the Board of Pharmacy before.
Totally fine. That was my question, yeah. Okay.
Yeah, but I can tell you that there are still people out there like it's not exactly what it says on the prescription.
Mm-hmm. Yeah, and maybe like corporate requirements or something too that tell them they have to do that.
Okay.
Yeah, I mean, as a prescriber, and this is Russ again, as a prescriber, I think it would be great to get those notifications, and also it's often complicated because, for instance, I haven't had this problem in Oregon, but when I was working in Washington, fluoxetine 60 milligram capsules were not covered. So if you wanted to prescribe 60 milligrams, you had. So anyway, so there are situations where it was necessary in order to get the dose that you needed. But I think, generally speaking, most of us would be totally on board. I love having things optimized without my input. I get enough faxes and emails and phone calls. So, I mean, I think it's, as a prescriber, I like the idea of just having it optimized. And then especially like with lamotrigine, I would love it if we could optimize that to 200 milligram tabs, because I get plenty of phone calls when I'm for refills on lamotrigine. Anyway, so I think the recommendations are great, but I mean, a simple fax would be plenty for me to say, look, here you're dosing this 2 tabs once a day. You know, we're changing it to 1 tab once a day. You know, let us know if you disagree, and that's all I would need.
But you want to have, say, please update the med list, their med list?
Yeah, I mean, I think that's important. You know, Epic enables the, I can get, comes with flags, but the last EMR that I was using did not. You know, and so I would just get a simple, like, patients requesting refill of fluoxetine or you know, Rexulti, without those little flags to say that the patient was taking it differently. So, yeah, I think it is so important.
Thank you, Kathy.
Great. So what I'm hearing from this is that it sounds like it's okay to move forward with this, with the added continuation of the prescriber notifications on the front end, especially when we add in new medication, and then making a form letter from the pharmacy side to that the pharmacist could use as a notification to the prescriber, as well as including in our pharmacist communication. This is something that they do not need to call the prescriber to do when they're not changing the interval or something like that. Is that a good summation?
Yes, you just want to be careful that the way you communicate this, the provider doesn't think it was done, but then the pharmacy never follows through and does it. You know what I mean? Like, you want to make sure there's an order there. That makes sense.
Yes, it would be. They would get the edits, the pharmacy would do it, and then they would notify the prescriber that it was done, rather than there being a lag time in between.
All right, so the recommendation is to implement the pharmacy POS added consolidate the meds.
So moved.
Second, this is Kathy.
All in favor?
Aye.
Aye. Aye.
Aye. Any opposed? Motion approved.
Great, thank you.
Very much. Well, now a blast from the past. Previous clinical coordinator Andrew Gibler has, as you heard on the top of the order for introduction, and he is going to be presenting idiopathic pulmonary fibrosis class update. For those following along on the phone, it's on page 260 in the packet. And Andrew, we'll turn it over to you.
Thank you, Roger. This class was originally reviewed by the committee in 2015 when pirfenidone and nintedanib were approved for the first time for idiopathic pulmonary fibrosis. And those 2 drugs continue to remain to be the only 2 drugs in this class. However, nintedanib recently received some expanded indications in the more of the broader sense of interstitial lung diseases last year and this year. The first approval was to treat chronic fibrosing interstitial lung diseases in patients with progressive phenotype, and the second indication was to slow the rate of decline of pulmonary function in patients with interstitial lung disease associated with systemic sclerosis or scleroderma. The class is really infrequently used. We typically have about 1 to 2 patients a quarter in the fee-for-service population on one of these two drugs. So with that, we'll go through to the systematic reviews. There were 4 of them that were of high quality, and many of them looked at the studies that have reviewed pirfenidone and nintedanib, which are generally in patients with mild to moderate idiopathic pulmonary fibrosis. A lot of them originally recruited from the phase 3 trials. But there's several agents that have been studied for a long time in this for this disease state, some older drugs, and a few of these systematic reviews looked at those as well. The first one looked at agents specific for pulmonary hypertension, specifically ambrisentan and bosentan, which are endothelin receptor antagonists, and sildenafil, which is a phosphodiesterase 5 inhibitor. They looked at several outcomes, including mortality, quality of life, and different surrogate endpoints that look at lung functions, such as forced vital capacity and carbon monoxide diffusing capacity. Didn't find any benefit for any of these agents in IPF, or idiopathic pulmonary fibrosis. The second one looked specifically at pirfenidone, nintedanib, but also N-acetylcysteine and azathioprine and sildenafil. And what they did is they found that few treatments other than pretty much just pirfenidone and nintedanib have any impact on clinical lung function. And so they concluded again that N-acetylcysteine, azathioprine, and sildenafil don't have any clinical benefit, but there was strong evidence, moderate evidence that pirfenidone and nintedanib does impact lung function and to various degrees different more clinically meaningful outcomes, such as mortality and exacerbations and IPF-specific related mortality. So in the next slide, you'll see there's a couple of systematic reviews that looked more specifically at that, and the third one looked at FDA-approved doses of pirfenidone and nintedanib. Found that they decreased the changes from baseline in FVC and improved the risk difference of FVC decline of 10% or more compared to placebo, and that nintedanib resulted in some acute exacerbation reduction. And N-acetylcysteine didn't provide any additional benefit compared to placebo and IPF. And then the last one looked specifically at pirfenidone and found that there were some clinically meaningful outcomes that were probably reduced when you combined all the studies together in a meta-analysis showing some improvement in all-cause mortality, IPF-related mortality, and progression-free survival. Pirfenidone has not shown to reduce acute exacerbations of IPF, but nintedanib has. And then there's this a high-quality guideline from a diverse array of organizations across the world, including the American Thoracic Society, and they also performed a systematic review. The guideline task force didn't make any strong recommendations for any particular treatment, but they did offer some conditional recommendations for the use of nintedanib or pirfenidone in IPF, in patients specifically with mild to moderate IPF, because of the potential benefits seen in these studies, and but just balancing that out with potential significant adverse effects, mostly GI related, and then the cost of treatment. They do acknowledge that there's no optimal duration of therapy. We still don't know if the treatment effect endures with ongoing therapy, but many of these patients with IPF, the prognosis is relatively poor, and the decline is fast. So they're not exactly have a lot of time on their hands, and so that's a rather difficult thing to probably study. But it might be possible with ongoing trials. They didn't make any recommendations otherwise. In fact, made some conditional recommendations against some of these other agents we talked about earlier. And then the two new indications that were reviewed for nintedanib that I discussed earlier, both based off of a single randomized controlled trial that looked at lung function. And you can see the results there. The primary endpoints for both trials were forced vital capacity, which showed that it slowed the decline of lung function in these patients with interstitial lung diseases versus placebo. They were statistically significant in both cases. Secondary endpoints in these studies that looking at things like quality of life, these were both 1-year studies, didn't find any additional benefit. But the FDA approved them based off of these primary endpoints. And then since we last looked at this class, the FDA has looked at updated some warnings around elevated liver enzymes and drug-induced liver injury. There have been some case reports and some post-marketing studies that show that liver injury can be serious, many non-serious, but there have been some fatal cases, so they do recommend regular monitoring of liver function monthly, usually in the first 6 months, and then every 3 months thereafter. And so our recommendations, if you can look at the PA criteria on Appendix 4, which is on page 280. Basically, we would like to update the PA criteria to approve nintedanib for adults with interstitial lung diseases with these new indications. No changes necessarily to the PDL status of these two drugs, and it would be appropriate, I think, to rename the class to drugs for interstitial lung diseases, which we would include any drugs in the future that are approved by the FDA for this broad class of disorders. IPF is the most common, but there's several of them. And then the last slide is just kind of highlights the approval criteria for these two agents. What we basically did was we broadened the indications to not limited to IPF, but these interstitial lung diseases have been approved. We removed specifically the criteria for forced vital capacity of patients that are greater than 50%, which would imply only starting these agents in patients with more mild conditions. There have been some randomized controlled trials that have studied these drugs in more advanced interstitial lung diseases. And then removing the criteria that against the concurrent use of pirfenidone and nintedanib, because there have been studies, clinical trials that have looked at the safety of these two drugs used together, and pharmacokinetic studies have shown that the drugs do not alter the effects or exposure of either drug to a patient when used concurrently. And so the combination has not been studied for efficacy. It's been studied for tolerability and safety, and that has been updated in the prescribing information for both drugs. And then just remove the renewal criteria, which we had required evidence of the disease hadn't progressed greater than 10% of the percent predicted FVC. And I really felt that, with the progression of this disease, that's a very, very difficult criteria possibly to meet in the latter stages of life, and to pull the drug off of someone because of that seemed clinically inappropriate. So that is the summary of the PA criteria and the new indications for nintedanib. Are there any questions?
Well, Andrew, thank you. Any questions for Andrew? And we don't have any public comment. One more second to unmute. So the recommendations in front of the committee are to update the PA criteria as proposed, no changes to the PDL based on the clinical information, and to expand the PDL class to include drugs with approved indications for interstitial lung disease,
which includes idiopathic pulmonary fibrosis, and the renaming as well.
So we need a motion to approve.
Motion to approve. This is Kathy.
Second, Oregon.
All in favor?
Aye.
Aye. Aye. Any opposed? Motion approved.
Great. page 282 in the packet, and turn it over to Megan Herring.
Thank you. Okay, so this is the class update and new drug evaluation. So here you can see the 4 currently approved cystic fibrosis transmembrane conducted regulator, or CFTR, modulators. Just a little bit of background. The ivacaftor is a CFTR potentiator, which increases the probability that the CFTR ion channel remains open, and the other 3 agents, lumacaftor, tezacaftor, and elexacaftor, are known as correctors, which help to correct the folding of the CFTR protein. So ivacaftor kalydeco is the only agent approved as monotherapy. They are approved for different genetic mutations, and kalydeco is approved for most of the gating mutations, the most common being the G551D, and then the others are a combination of either 1 or 2 corrector with ivacaftor. Orkambi is approved for those patients homozygous for the F508del mutation, which accounts for about 50% of the cystic fibrosis population. Symdeko is also approved for those homozygous as well as for any of the other responsive mutations. And then the most recent drug approval, which we will talk about more, is Trikafta, which is a combination of 3 agents, and it is approved for patients 12 years of age and older who have at least 1 F508del mutation. This is the most common mutation in the United States, so about 90% of people with CF will have at least 1 mutation in the F508del. Next slide. So looking at the evidence identified for the class, there were 2 Cochrane systematic reviews that were identified since the last review. One of them evaluated the effects of the CFTR potentiators, or ivacaftor, in the following population. So overall, the quality of the evidence was moderate to low. All of the trials were funded by Vertex. In those homozygous for F508del, there was moderate quality evidence of no significant effect on lung function or quality of life, and ivacaftor is currently not approved for this population. In the R117H mutation, there was moderate strength evidence of a significant improvement in the Cystic Fibrosis Questionnaire Revised Respiratory Domain Score, but with a difference from placebo of 8.6 points. However, there was no improvement in lung function measured by percent predicted FEV1 change from baseline. And then in the gating mutations, most commonly studied the G551D, there was moderate strength evidence of a significant improvement in lung function with an absolute mean difference of 10.8% in FEV1 compared to placebo, as well as a decrease in pulmonary exacerbations at 48 weeks. The other Cochrane review evaluated the effects of the correctors, so lumacaftor and tezacaftor. At the time of this report, the Trikafta agent was not yet FDA approved, so it was not included in this. And this is in class 2 mutations, which are the protein processing mutations, again, which the most common one is the F508del. So there's high-quality evidence of a significant but small improvement in respiratory domain quality of life, the mean difference of 2.62 with Orkambi, and moderate quality of evidence with Symdeko with a mean difference of 5 points. And there was also high-quality evidence of a small improvement in lung function. I'm going to make a modification to this slide with an absolute difference of 2.4% with Orkambi compared to placebo, and an absolute difference of 4% with Symdeko and placebo. And moderate quality of evidence of a decrease in pulmonary exacerbations with both agents compared to placebo. And so the recently approved drug, again, is Trikafta. So the newest CFTR corrector is elexacaftor. And so it binds to a different site on the CFTR protein than other current therapies, and is theorized to have an additive effect with tezacaftor in facilitating the cellular processing. And so triple therapy is approved again for patients with at least one F508del mutation in the CFTR gene, of which approximately 90% of individuals will be eligible for treatment with this agent. And just looking at utilization in our population, we have had the first quarter of 2020, there were about 20 claims for Trikafta. So in terms of approval studies, the Trikafta was FDA approved based on two phase 3 randomized controlled trials in two different populations. The first trial by Regiment et al. Compared Trikafta to Symdeko in patients who were homozygous for the F508del mutation over 4 weeks. All patients did undergo a 4-week run-in period with Symdeko prior to randomization. And the second trial compared Trikafta to placebo in patients heterozygous for the F508del and a minimal function mutation. The primary outcome in both trials was the absolute change in percent predicted FEV1 at week 4. So treatment with Trikafta did result in statistically significant improvements in the FEV1 at week 4 compared to Symdeko. And you can see the treatment difference, the absolute treatment difference was 10% between Symdeko, and in the heterozygous population, the treatment difference was 13.8% compared to placebo. There was also a significant improvement in the respiratory domain of quality of life, the treatment difference of 17.4 points. And the first trial was only 4 weeks, so it was too short to evaluate other outcomes, including pulmonary exacerbations, but the trial against placebo, there was a significant reduction in pulmonary exacerbations with a rate ratio of 0.37. So some of the trial limitations I want to point out, both the trials were funded and influenced by Vertex Pharmaceuticals. I mentioned there was a 28-day screening period in both trials and an additional 4-week run-in period in the trial where Trikafta was compared to Symdeko. The FDA did recommend including in elexacaftor and ivacaftor as a treatment arm to evaluate the benefit of adding a second corrector, which was not done in the clinical trial. FEV1 is a surrogate outcome. There is no clear evidence that changes in this outcome translates into a long-term clinical benefit in this population. And lastly, the clinical program of this drug did not specifically evaluate all mutations covered under the broader indication of cystic fibrosis with at least one F508del mutation. Here are the most common adverse drug reactions that were seen in clinical trials. There were no differences in serious adverse events or discontinuations. However, the short duration of these trials does make it difficult to evaluate for long-term safety concerns. The severe adverse events that did occur suggest for the potential for clinically significant elevations in liver transaminases and creatine kinase abnormalities. Additionally, this drug has not been studied in patients with moderate or severe hepatic impairment, and all three of the drugs in the combination are extensively metabolized by CYP3A4 and should not be used with strong inducers or inhibitors of CYP3A4. And so our recommendations are to maintain elexacaftor, tezacaftor, ivacaftor as non-preferred and add it to the clinical prior authorization criteria with the other oral cystic fibrosis modulators, and to update the prior authorization criteria as is in the packet. The PA criteria starts on page 301. And some of other than just adding this drug into the criteria when appropriate, some other changes that we are recommending is the initial approval for these drugs was for 3 months, and we are recommending to lengthen that to approve for 6 months initially, as you can see in number 13. And then the next slide is the renewal criteria. So we do have renewal criteria asking that patients are adherent and tolerant to therapy and that they do have a documented response to therapy, as you can see in number 2. So we did remove the requirement for the for ivacaftor only to get a sweat chloride test to document physiological response. That used to be in the renewal criteria. And then lastly, again, the renewal criteria was approved for an additional 3 months, and we are recommending to approve for an additional 12 months after the initial approval time. And those are the recommendations, and I'll take any questions.
Thanks, Megan. Any questions for Megan? We do have some public comment. We have Lisa Allen from Vertex. Let me find your line here, Lisa, so I can unmute you.
I think I'm already unmuted, Roger.
Okay. Then with that, I will share my screen, and the clock is yours.
Thank you. Good afternoon. My name is Lisa Allen with Vertex Medical Affairs. Thank you for the opportunity to provide testimony on behalf of the CFTR modulator class. Cystic fibrosis is a progressive and life-limiting disease. The CFTR modulators are systemic treatments that target the underlying cause of CF, which is a defect in the CFTR protein. I am testifying today because despite the committee's awareness of the progressive nature of CF, OHA continues to delay access to CFTR modulators by requiring an additional review by a medical director for select patients. I respectfully request the removal of approval criterion 8, as patients with CF with an R117H mutation have this progressive life-shortening disease, and an unnecessary delay in therapy initiation after their practitioner has determined that they may benefit from treatment could result in undue disease burden. I'm also requesting the removal of approval criterion 10, as Orkambi has been indicated for the treatment of F508del homozygous patients ages 6 to 11 years since 2016 and patients 2 to 5 years since 2018. Now I would like to address several restrictions in the OHA policy which are not based on scientific or clinical evidence and deny access to members with CF who are indicated for CFTR modulators. Approval criterion 12 requires the use of all 3 listed pulmonary therapies prior to initiation of a CFTR modulator and is not appropriate for every individual based on the benefit-risk of therapy, tolerability, and the patient's medical history. This criterion is not reflective of clinical practice, and decisions regarding appropriate therapy should be left to the treating physician. Also of concern is renewal criterion 3. This is not evidence-based and puts an OHA member with CF at high risk for interruption or denial of therapy. The symptoms and disease manifestations in an individual depend on the stage of disease at a modulator initiation. And the clinical response in each patient will differ, and for this reason, a patient's response is best assessed by the treating physician. Now I'd like to turn to Trikafta, a triple combination therapy for patients 12 years or older who have at least one F508del mutation in the CFTR gene. As Megan said, both registrational studies for Trikafta met their primary endpoint of an absolute change in FEV1 from baseline at week 4. They also saw significant improvements in all key secondary endpoints, as well as a significant increase in BMI and a 63% reduction in the number of pulmonary exacerbations as compared to placebo. As a reminder, there are patients with CF who are currently eligible for Kalydeco, Orkambi, and Symdeko, and are not eligible for Trikafta based on genotype and or age. The full indications and complete list of warnings and precautions can be found in each product's respective USPI. Based on the rationale that Vertex previously provided in writing to the committee and my testimony here today, I respectfully ask that OHA allow all eligible members access to CFTR modulators in accordance with their FDA-approved indications. Thank you for your time, and I'm happy to answer any questions you may have.
Any questions for Lisa? Great. Thank you, Lisa.
Thank you, Roger.
We'll bring the criteria back up.
Pat here. Looking at approval criteria number regarding Orkambi. It does seem that the FDA label does go down to 2 or 3 years of age. And looking at the studies, I couldn't find a good reason for item number 12 regarding age. Now, if anyone has any thoughts.
Yeah, so the reason for that was, so if you saw from just even the data presented today, the absolute benefit with Orkambi seems to be smaller than the other agents. So in general, an absolute difference of 2.4 in terms of FEV1. And then in the initial studies in the population of those aged 6 to 11, I believe there was not a benefit seen, and it actually favored placebo in that group. So at the time when we reviewed the drug, it was decided to, for that population, to refer to medical director for kind of a further assessment of potential benefit.
Thank you.
Other questions for Megan? And Pat, on following up, did you have a recommendation or move to change that, or Megan's answer is sufficient?
No, I didn't notice that the effect size was a bit smaller for the younger folks. I think that seeing as prior thought has been put into this, I don't think I feel strongly enough to take it further.
Super. Other questions for Megan? All right, so the recommendations in front of the committee were to maintain Trikafta as non-preferred and to add PA criteria, update the criteria as proposed, including the initial approval of 6 months and 12 months for subsequent approval. Any other verbal amendments, Megan?
Nope.
So we'd need a motion.
Move to approve.
Second. Pat.
Okay, then, all in favor?
Aye. Aye.
Any opposed? All right, motion approved. I did the any opposed pretty quickly, knowing that it's unlikely, but in case we ever go too fast, I don't want us to not miss somebody who's opposed, because that's important. So you just have to remind us if we go too fast.
So for the committee, just 2 things. We have 2 more topics left on the agenda. I think the laxatives for chronic constipation will go pretty smooth. No pun intended. And the Gamma fan, we have delayed multiple times, but I think we can get to it. We will be going to executive session, but that will be a separate call. And I have sent an email to the entire committee. So with that, I'll turn it over to Deanna. And for those following along in the packet posted online, we're on page 311. Again, for the committee, if you'll just check your email if you have a chance, make sure you received a secure email from me, as that'll be necessary for us once we're ready to move into executive session.
Okay, thank you, Roger. Sarah, if you could move the slide forward. The reason we were doing this update was just to see if there was any new evidence that should be incorporated into our PA guidance. The last time we talked about constipation was July 2017, when we did abbreviated drug reviews for plecanatide and naldemidine. Just as a reminder, constipation, irritable bowel syndrome with constipation, and opioid-induced constipation are currently not funded under the Oregon Health Plan Prioritized List of Services. Funding for drugs that treat constipation is dependent on whether the constipation adversely affects or is secondary to an underlying medical condition that is covered by the prioritized list. Therefore, we implemented prior authorization criteria to help guide decision-making for non-preferred drug utilization in those funded conditions. The prior authorization criteria are included in Appendix 3 on page 332. Just as a reminder, Appendix 1 on page 326 gives you the rather lengthy list of preferred and non-preferred drugs. I'll just highlight that the non-preferred drugs include linaclotide, methylnaltrexone, naloxegol, naldemidine, alzimipam, lubiprostone, and plecanatide. Pretty much all the other laxatives are preferred. In the fourth quarter of 2019, 100% of the Oregon Health Plan fee-for-service utilization was for the preferred agents. We could go to the next slide. Thank you. So there were 3 systematic reviews that were identified. 2 of them were from Cochrane. The third one was a high-quality systematic review. Just to let you know that most of these systematic reviews were limited by sparse and heterogeneous data that came from trials with a high risk of bias. So the first Cochrane review basically looked at osmotic and stimulant laxatives in children with chronic idiopathic constipation, and they concluded that polyethylene glycol preparations may be superior to placebo, lactulose, and milk of magnesia, but that was low-quality evidence. Then the second Cochrane review looked at safety and efficacy for the mu-opioid antagonists for alleviating opioid-induced constipation. This was just in adults with cancer who had palliative care. And this review suggested that naldehyde improves bowel function in patients with OIC in whom conventional laxatives have failed. And then we had moderate quality evidence from 2 trials that suggested methyl naltrexone improves bowel function. And then the third systematic review also evaluated the efficacy of medications approved to treat OIC, and it wasn't just limited to cancer patients. Again, they thought that lubiprostone and prucalopride had favorable response compared to placebo, with the overall number needed to treat of 5. Overall, lubiprostone was the least efficacious, and then they did note that adverse effects, as would be expected, were higher in the patients that received drug versus placebo, with a number needed to harm of 20. Next slide, please. So there was 3 pertinent guidelines that were also released. So the American College of Gastroenterology updated their irritable bowel syndrome guidelines, and they recommended that psyllium be recommended first line in patients with IBS with constipation. And then they also recommended that linaclotide, plecanatide, and lubiprostone can improve symptoms in patients with IBS. Constipation prevalent compared to placebo. The Canadian Association of Gastroenterology also came up with some guidelines, again, recommending fiber supplementation initially for IBS-C, and then they looked at linaclotide. They did not look at plecanatide because it's not commercially available in Canada, and they kind of ruled out lubiprostone because it's so expensive. The third guideline is on the next page, and that was from the American Gastroenterological Association for the medical management of opioid-induced constipation. They do not recommend lubiprostone or prucalopride. They recommended to use laxatives as first-line agents, followed by naldehyde and naloxone. Let's go to the next slide. So we do have some new formulations and new indications to this class. So prucalopride was approved in 2018. It's a 5-HT4 agonist, and it's indicated for chronic idiopathic constipation. Then we have tenapanor, which also was approved. Well, this was approved in 2019, and it's approved for IBS with constipation. Then there's lactitol, which is an oral solution that received approval earlier this year, and that's an osmotic laxative indicated for chronic idiopathic constipation. And then finally, tegaserod, which was previously on the market and was withdrawn in 2007 due to reports of cardiovascular events. It's been reintroduced to the United States market. The FDA reapproved it for use in irritable bowel syndrome with constipation in women under 65 years of age. The safety and efficacy of tegaserod has not been established in men. So that leads to the next slide with the safety warning. So just reiterating that the package label was revised for tegaserod to include those additional contraindications in patients that have cardiovascular risk, as well as there's been some reports of suicidal ideation. So with that, I will move to the recommendations. So the recommendations are to designate prucalopride, tegaserod, and tenapanor as not preferred on the PDMP, and to revise the PA criteria we have for the laxatives to include those 3 drugs, and then we can review the costs in exec session. This is the PA criteria. There was no changes to the first four statements. Number 4 talks about if we are getting a request for a non-preferred agent, have they at least tried 3 of the following management recommendations, and if they have not, then it goes to the pharmacist. And number 5 is on the next slide. That's where all the changes are. So I just moved naldenamide to its own line, and originally it was with methylnaltrexone. And then the 3 drugs we talked about were just added at the bottom to help give the pharmacist some guidance as to what can be approved or not approved based on what's funded. And with that, I don't think we have any public comment, do we?
That's correct.
Okay. Are there any questions? I know I went through that pretty quickly. So the points for the P&T committee, if there's no questions, are do you approve that we recommend these 3 agents as non-preferred? And do you approve the criteria as outlined?
For that, we need a motion to approve.
I just want to check that there's no discussion before we move to the motion. Doesn't sound like it. Okay. Motion to approve?
Second. This is Kathy.
Great. All in favor?
Aye.
Aye.
Any opposed? Okay, motion approved.
Okay, one more class, and we do have public comments, so if you'll bear with us, we'll turn it over to Dave. For those following online, page 335 in your packet.
All right, thank you, Roger. So today I'll be discussing the new drug emapalumab, or Gamifant. And Gamifant is a monoclonal antibody. It's indicated for the treatment of primary hemophagocytic lymphohistiocytosis, which we'll refer to as PHLH in this presentation. So it's for patients with recurrent or progressive disease, refractory to or intolerant to conventional therapy. HLH is a very rare condition, and primary HLH is a subset of HLH. And these are patients with a genetic basis for the immune system dysregulation and the hyperinflammatory immune response that we observe in this disease. If you look on the next slide, conventional therapy for PHLH includes a regimen of etoposide along with dexamethasone, and it's administered at regular intervals until the patient's ready for hematopoietic stem cell transplantation. Next slide. Gamifant studied in a small 8-week multi-center phase 2, phase 3 trial. It was open label, single arm, and multi-center. There are 34 patients that met the criteria. And you can see the primary outcomes. There are proportion of patients with complete response, which would be normalization of signs and symptoms, or partial response, 3 or more areas of complete response, or no disease progression, or HLH improvement, which was defined as 50% or more improvement in at least 3 of those HLH clinical and laboratory abnormalities. And the outcomes were assessed at 8 weeks, or until stem cell transplant, which was between 4 and 8 weeks. The next slide. The study was unable to demonstrate a statistically significant response for the treatment-naive subjects, but for the remaining 27 patients with treatment-refractory disease, 17 of those patients, or 63%, were reported to have statistically significant response. 26%, or 7 of those patients, were considered complete responders. 30%, or 8 of those patients, were partial responders. 7%, which was really 1 patient, demonstrated HLH symptom improvement. If you look at the next slide, there are some limitations. A few efficacy in treatment-naive patients was not able to be statistically evaluated. The median age of the study population was 1 year old. There was an open-label study design, and then the true incidence of infection was unclear due to HLH itself, the disease, and the drug treatment both having effects on immune function. So if you look at the next slide, as far as safety, the highest incidence of adverse effects besides the infections were hypertension, infusion-related reactions, and fever. Next slide. So therefore, based on this review, I recommend create a preferred drug list, class for drugs for hemophagocytic lymphohistiocytosis, designate emapalumab as non-preferred, and implement clinical prior authorization for emapalumab to ensure appropriate utilization. And so let's take a look at that PA criteria. It's fairly straightforward. You look at step 1, it creates a pathway for renewal. Steps 2 and 3, obtain diagnosis and review the funding level. Step 4 and 5 hits on the appropriate indication and confirmation that the patient's HLH is of the genetic origin. Step 6 keeps in the purview of an appropriate specialist. 7 through 11 deals with appropriate concurrent therapy and safety aspects. Step 12, you'll see it mobilizes case management to help monitor adherence. And then we can look at the renewal criteria. Basically, 1 through 5 reiterates the important safety and efficacy assessments. And that should continue until a patient is eligible for stem cell transplant, which is the goal. So that's it for the Gamifant review. We can stop for public comment and P&T discussion or questions.
Any questions for Dave? Okay, hearing none, we do have public comment. Robert Alstrom with SOBI. I am looking for your name. If I can introduce you. My computer is not cooperating. There we go.
Can you hear me?
Can you hear? You bet. We can hear you. So again, you can quickly introduce yourself, and I'll get the screen up for you.
Excellent. Thank you. Appreciate the opportunity to address the community today. My name is Robert Alstrom, Medical Science Liaison with SOBI, and I'm here to just provide some comments on Gamifant and emapalumab for treatment of adults and pediatric patients with primary hemophagocytic lymphohistiocytosis, or HLH, with refractory, recurrent, or progressive disease or intolerance with the conventional therapy. So I just wanted to point out a few things about primary HLH. It's very rare. You may never see it, but in 2017 there were 81 cases in the U.S. It's rapidly progressing, it's life-threatening, and it typically affects infants and children. The diagnosis can be challenging as it can mimic a number of other diseases, sepsis, for example. The gold standard for diagnosis is genetic confirmation, but that may take up to 8 weeks. So physicians have to rely on a clinical diagnosis where patients have to fulfill 5 out of 8 criteria, and these were established by the Histiocyte Society. And there also needs to be an absence of an underlying trigger such as malignancy or rheumatic disease, which would make it a secondary form of the disease. So primary HLH, it's characterized by a hyperinflammatory state, and although patients can be cured with hematopoietic stem cell transplant, the inflammation needs to be brought under control before that can happen. And there are no currently FDA-approved therapies in this disease, but the current standard of care was typically follows the guidelines that were established by the Histiocyte Society in a 1994 trial, and it consists of immunosuppression with dexamethasone chemotherapeutic agent, etoposide. So despite the efficacy that was shown in this trial, the H94 trial, using these agents, there are still patients that fail to respond, they stop responding, or they flare up and become inflamed before the transplant can be performed. And so it's this sort of refractory or relapsing or intolerant population is the one in which Gamifant was studied, and it received approval from the FDA. So it is a bridge to the curative therapy, which is the stem cell transplant in these patients that have failed prior therapies. So I'm not going to go through the PI data. I think you guys did a good job of going through the results from the study. I'll just add that our primary manuscript was published in the New England Journal of Medicine on May 7th, just over 3 weeks ago. And I'll be happy to answer any questions that you have on that.
Thank you for that, Robert. D&D Committee, any questions for Robert Alstrom? Okay, thank you very much. I'll turn it back over to you, Sarah, to bring the screen back up. And again, the recommendation that we had when the review date started was to add the class to the preferred drug list for hemophagocytic lymphocytosis, designate and mepulimab. I should just let you do the same because I'm just going to butcher them.
You do great.
Designate and mepulimab is non-preferred, and to implement the proposed PA criteria for hemophagocytic.
Motion to approve. Pat.
Second that, Helm. All in favor?
Aye.
Aye. Any opposed? Motion approved.
Well, we made it through that, so thank you, everybody. We do need to go into executive session. Sarah's putting a slide up on the screen. I need to read a blurb. Because of the security of Zoom or lack of, we have to actually drop off this and join a separate call for the P&T committee. I sent you an email a while ago that has a conference line and the confidential pricing. So we will mute all the lines on this side after I make my announcement, and then join that conference line, talk through the pricing. We won't make any decisions, but we'll rejoin and invite the audience back when we unmute our lines and make final recommendations before we conclude the meeting. So
I could not open up your email, Roger.
Nor could I. It said you had to open it by a certain time, and I didn't see it until after that.
Oh, there's that. Yeah, Sarah, would you be able to resend the information, send the conference line unsecure, and then send a secure email with the pricing? And with that, I'm going to read announcement. And so for the committee, you should be checking your emails. You'll have a conference line, and I'll join on that in just a moment. The P&T committee will now meet in executive session for the purpose and consideration of information or records that are exempt from disclosure by law. The executive session is held pursuant to RS 1926602F and RS 4143551 and 2, which allows the P&T committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class that is necessary for the committee to make final recommendations or to comply with the requirements of House Bill 2100. Representatives of the news media and designated staff shall be allowed to attend the executive session. All other members of the audience are asked to stand by before we return to Zoom. Again, no decisions will be made in executive session. At the end of the executive session, we'll return to open session and welcome the audience back as we start to resume our conversations. Thank you very much. All right. I think we have everybody back from executive session. After review and executive session, I just want to confirm with the committee I was going to make all of the recommendations that we have, and you can make one motion and approval of all of them. Seeing some heads nod. So
So after review and executive session for the acne class, the recommendations were to make altreno, which is tretinoin, and arazlo, tazobutrazine, non-preferred, and all the unassigned benzoyl peroxide products preferred, as they'll all be subject to PA criteria. For the anti-epileptics, make no additional changes to the PDL. For the oral diuretics, make chlorothalidone and generic triamcinolone hydrochlorothiazide products preferred. For the sickle cell disease, make hydroxyurea capsules preferred, and Droxia, Hydrea, Cyclose, glutamine, crizolizumab, and voxelotor, non-preferred. And finally, for the laxatives for chronic constipation, we already had made recommendations in open session to designate prucalopride, tegaseride, and tenofovir non-preferred, or unfunded. And the other recommendation from exec session is to make no additional changes to the PDL. And with that, either have any questions or we need a motion.
Move to approve.
Second.
All right, all in favor?
Aye. Aye.
Any opposed? That is approved. Great job, staff, in helping us conduct a meeting this way.
Right. I really appreciate everybody's patience. You did a great job. The next PNC meeting is scheduled to be held August 6th. So again, we'll send out information. You'll have notification when we post draft and final documents. So that concludes this meeting. However, I just wanted to remind everybody this also serves as a Rules Advisory Committee for the Oregon Health Authority. So I know Brandon and Jennifer and Dee are on board. So with that, the committee, you're excused, but we need to unmute the lines to see if there's anybody that has any public comment for the OHA as a RAC. Again, thank you, committee, and I'll be opening up the lines.
Thank you.
Thank you.
Everybody.
Have a good summer.
Thank you.
Stay safe.
Trying to unmute all. If people are online and they wish to provide public comment, you can raise your hand, but I'm trying to. It says everybody's unmuted, so you must be muting your own lines.
Was there anyone that... Sounds like maybe nobody...
Yeah, leave it to you.
Yeah, I think we can wrap up.
Thanks, everybody.
Thank you.
Team, you did a great job.
Bye-bye.